All right, so health promotion. So our objectives for health promotion, we are going to be able to describe concepts and models of health, wellness, and illness. We're going to be able to compare and contrast acute illness and chronic illness, explain how human dimensions, basic human needs, and self-concept influence health and illness, describe the role of the nurse in promoting health and preventing illness, and then we're going to explain the levels of preventative care. We're going to differentiate complementary and alternative medicine from allopathic medicine. We're going to describe ways in which nurses can use knowledge of complementary and alternative modalities when we provide patient care. We're going to identify the knowledge that the public should possess about that complementary therapy if they wish to be informed consumers. So the chapters that we were dealing with in your book are chapter 3 and 28. Okay. So health is more, it's not just an absence of illness. It's what they consider an active process in which a person moves towards their own maximum potential. Every person has their own idea or definition about what health means to them. It's based on their values, it's based on their beliefs, their culture even has a lot to do with it, the communities that they live in or they were raised in, and then their societal influence. So because health is because the definition of health is left up to each individual, there's opportunities for people who might appear to be unhealthy, but they're not really unhealthy, or they might not consider them healthy. So the example I want to give is the patient who maybe there's a woman who was in an automobile accident and she lost one of her legs. Just because she has an artificial limb or she lost a limb, you guys should never think of that patient as being unhealthy, and you should expect that they won't also see themselves that way, because as far as they're concerned, they still might be eating properly, they still might be exercising, they're taking their vitamins, they're doing all the things they need to do. So don't just assume when you're dealing with people who have dealt with certain things, certain physical issues, that they are unhealthy, because they are not, and don't expect them to think that way about themselves. Okay, so morbidity and mortality. Morbidity is the frequency of how often a disease occurs, and mortality is the number of deaths that result from a disease. So when we look at the health of the public, this is how we measure it. We measure it on a global level, and we look at morbidity, and then we also look at mortality. Wellness. Wellness is a term that we use often interchangeably with health. They pretty much mean the same thing. It is what we consider to be an active state of being healthy. It includes living a lifestyle that promotes good physical health, good mental health, and good emotional health. It involves the ability of us as humans to adapt to emotional issues and physical issues throughout our changing state of health and our environment. So these are the human dimensions. All of these interdependent parts compose what we are as a whole person. So we have intellectual, our environment, our spiritual values, our socio-culture influences, our emotions, and then our physical. All of this together compromises us as a whole. All right, so there are many different human dimensions that they believe that affect our health. So there's the physical dimension. So this would be our genetic inheritance. So what we inherit from our mothers and fathers, grandparents, sisters, brothers, our age, things that are based on developmental level. It can be our race and also our gender. And it affects our ability to be able to form activities of daily living so that we can maintain high functioning. We have an emotional dimension, and this is how the body affects the mind. This is how the mind affects the body function and how it responds to the body's condition. It looks at how we adapt to stress and how we express and identify with the emotions that we feel. The intellectual dimension, this is our cognitive abilities. So this is our educational background, what we've learned, how much education we have, what are we capable of understanding. And it also includes our past experiences. It affects our ability to learn and disseminate information. Our environmental dimension, so this is our housing, sanitation, our climate, this would be the pollution of the air, our access to food and clean water, and it creates measures that allow us to improve our standards of living and our quality of life. Then we have our socio-culture dimension. This is our economic level, the lifestyle that we live, our family, the culture, and this interacts successfully with others. And then we have our spiritual dimension. So these are our beliefs and our values. And then we, as we grow, we adopt different beliefs that provide meaning to the life that we live.
Excuse me, Miss Davis.
Yes.
Can you let Chizoma in?
Yes, thank you. Okay. So we talked about health, so now we're going to talk about the opposite. So the opposite of health, obviously, is disease. So disease is a medical term that refers to pathological changes in the structure or function of our body or our mind. So in your book, box 3.1, there is a nice chart that gives you different causes of different diseases. So there are some diseases that we have that we inherited from our other family members, and some that are genetic defects that occurred when we were being formed. Then we have developmental defects that result from certain exposures to maybe viruses or certain chemicals when our parents were pregnant with us. There's biological agents or toxins. Some of the biological toxins or agents that you could think of, chemotherapy. So we give patients chemotherapy to cure one thing, but we wind up sometimes causing other cancers and other issues because it's toxic to the body. It kills everything. Smoking cigarettes, a person's work environment, pollutions, things like that. Then we have physical agents such as temperatures, chemicals, and radiation. Generalized tissue responses to injury or irritation. Physiologic or emotional reactions to stress. And then excessive or insufficient production of body secretions. So our hormones, enzymes, and stuff like that. So an illness is the response of the person to a disease. It's how we react when we find out that we have something wrong with us. It's a process in which the person's level of functioning is changed when compared with that of a previous level. There's acute illness and chronic illness. The response that each person experiences to an illness is going to be unique for each person. You may handle an illness completely different than I would. It is influenced by their self-perceptions, other people's perceptions, the effects of the changes that we're seeing in our body from the illness or the disease, and how it's decreasing our function, and the effects of those changes from that illness, how it has an effect on the roles and relationships with our loved ones and our friends, and how it affects our cultural and spiritual values and beliefs. So if a person has an acute illness, a person can have an acute illness and a chronic illness both at the same time. An An acute illness usually has a rapid onset of symptoms and only lasts a relatively short amount of time. You could have a person, like I said, that has a chronic illness and develops an acute illness. So if you think of the diabetic patient, that's a chronic illness. They're going to have diabetes for the rest of their life unless they make a lot of changes to prevent it. But they can have maybe an episode of severely low blood sugar, which would cause them to have to go to the hospital. That would be an acute illness. So it's just something that happens for a small amount of time. Once you get to the bottom of the problem, it's not there anymore. So it is possible for these patients that have these chronic issues also to present with these acute issues. So our chronic illnesses, different from the acute, chronic illnesses encompass a number of different physical and mental alterations in our health. It's a permanent change. It's not that short, temporary issue. It's a permanent change. It causes or is caused by irreversible alterations in a person's normal anatomy and physiology. It requires some sort of special education or rehabilitation. It requires a long period of care or support. Chronic illnesses usually have a very slow onset and have many periods of remission. So the disease is present, but the person does not always experience symptoms and exacerbations. So some patients who have COPD, they don't always have exacerbations. They live their life, they take their medicine, they're completely fine, and then something happens in their environment, stress, or they get a cold, and it triggers that exacerbation. And then the symptoms of that disease reappear again. So a good example of some chronic illnesses is the diabetes, lung disease like COPD or emphysema, arthritis, lupus, heart disease, strokes, and obesity. These are all chronic illnesses. Okay, so there are different stages of illness behavior. So stage 1 is when we start experiencing symptoms. So this is how do people define themselves as sick? Well, it's the first indication of an illness, is usually recognized by a person with either one or more symptoms that are incompatible with what their own personal definition of health is. So it's not the norm. If the symptoms last for a very short time or they're relieved by self-care, then the person doesn't usually take any further actions. If the symptoms continue, however, that's when the person goes into the next stage. So stage 2 is assuming the sick role. So now the person self-defines themselves as being sick, and they're going to seek validation of this experience from others. They might give up on their normal activities and they might assume the sick role. So normally if we feel fine, we go out every day, we go to the grocery store, we go to dinner, we go to work, we do everything we're supposed to do. But when we take this sick role in that stage 2, maybe we're not going to go out. Maybe we're not going to go to work. We're going to stay home. We're going to stay in our pajamas. We're going to stay in bed. We're going to sleep more. So that's assuming that sick role. At this stage, most people focus on their symptoms and their bodily functions. Some people may choose to do nothing at this point. Some may research symptoms on the internet. Some people might go and buy over-the-counter medications. They might try alternative remedies to relieve symptoms, or they might actually seek out the healthcare provider to actually be diagnosed and treated. Oops. I don't know why my mouse is not moving tonight. I have to click it like 100 times. Come on. Okay, so we did stage 1 and 2. So stage 3 is when we assume a dependent role. So this stage is going to be characterized by the patient's decision to accept the diagnosis that the doctor gave them and then follow the prescribed treatment plan. Some patients, depending on the illness, may initially have difficulty conforming to the recommendations that healthcare provider gave them, and they might decide to get a second opinion or even just deny the diagnosis altogether. If the disease is serious, such as a heart attack or a stroke, the patient may be forced to enter into the hospital because they need more treatment. If the symptoms can be managed by the patient or by family alone or with the assistance of home care providers, then the patient obviously can be cared for at home. So stage 4 is achieving recovery and rehabilitation. So recovery and rehabilitation might begin in the hospital if they're in the hospital, and then it concludes at home. So we don't always keep people in the hospital until they're completely well. We get them to the point where they're stabilized and we feel like they're not in any, they're not in harm anymore. They can go ahead and finish their recovery at home. Sometimes it's at home. Sometimes it ends up in a rehabilitation center, especially for our older population. Most patients complete this final stage of illness at home. In this stage, the person gives up the dependent role and they start resuming those normal activities again and their previous responsibilities. If the care plan includes health education, the person may return to health at a higher level of function and health than before the actual illness. So disparities in healthcare. So a health disparity is defined by Healthy People 2020 as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. So Healthy People 2020, they do these every year. You're going to hear a lot about these as a nurse. They do them 5 and 6 years out, and they do them as sometimes 7 or 8 years. They do, they look into the future and they say, like in 2010, they said, what do we expect from people in 2020? What do we want? And that's what they call it, Healthy People 2020. Well, this is what we want to see people doing. And they set goals. And then those goals are passed on through the Joint Commission and through the hospitals and things like that, so that all the healthcare providers are on the same page at what, with what they expect healthy people to look like and how we can attain that. So that's what Healthy People 2020 is. So what are some factors that affect health disparities? So race, ethnicity, poverty, biological sex, a person's age, the mental health of a person, their education level, any disabilities, sexual orientation, access to health insurance is a big one, and then access to health care. So lack of these or issues with these risk factors can cause health disparities. So what effect does illness have on a family? So most of the care that we provide as nurses is always going to be focused on the patient. But when an illness occurs, especially a pretty serious illness, it changes the daily life for not only the patient, but their family too. So we have to think about the whole family. I mean, the patient is always our priority, but we have to include the family and we have to think about them, especially if when the patient goes home, they're requiring a higher level of care and family members are going to pick up that slack and care for the family member at home. They're going to need support. So chronic illnesses create stress for the patient and the family because these long-term alterations in their previous roles, in their present lifestyles. Some people are frequently hospitalized. They're not able to work. It causes economic problems. They have decreased interactions with friends and family members. So it all comes together. When we think of it from a parent perspective, so parents of a sick child will often react with blame. They want to blame someone. They'll be overly protective of their children. They might have a lot of anxiety because they can't control what's going on. Family members of patients requiring care in the intensive care often feel alone and frightened. And in both cases, these examples that I gave you, they might also feel guilty and then also think about the worst possible outcome. All right, so there are many different factors that affect or influence a person's health status, their beliefs, and then ultimately their health practices. These factors can be internal or external, and they may or not even be conscious to the person. They might not even realize it. As nurses, we need to plan and provide holistic care. So we need to understand how these factors are going to influence the behavior in both healthy patients and ill patients. So when we talk about basic human needs, basic human need is something that is essential. It's a must. These needs have to be met in order for emotional and physiologic health and survival. People can't live without them. A person whose needs are met are usually considered to be healthy, and a person who has one or more unmet needs is at risk for illnesses. The human dimensions, so the factors that influence a person's health, illness status, their health beliefs, and their health practices are said to be related to a person's human dimensions. Each dimension interrelates with each of the other, and then it influences the person's behavior in both their health and in their illness. As nurses, we need to make sure we're thoroughly assessing our patients. We want to look at their strengths and their weaknesses in each dimension so that we can treat them holistically. And this is going to help us individualize their care plans that we make for them. So doctors make medical diagnosis. So they figure out what's wrong with the patient, they treat them, and then their job is done. When we're treating them, when they're in the hospital, we're treating their whole person. That's that holistic care that we're talking about. We're thinking of their physical abilities. We're thinking of their psychosocial abilities, what their environment is at home. We're looking at all these components that we know affect a person's health and illness. So we really need to make sure we're looking at our patients' strengths and their weaknesses so that we can individualize their care and promote good health outcomes. So when we look at the human dimensions, there are a couple different, the dimensions are physical, emotional, intellectual, environmental, social, culture, and spiritual. So physical is that genetic inheritance, the age, the developmental level, that race. These all play an important role in influencing their health status and their health practices. I think we talked about this before. Our emotional is how our mind affects our body functions and how we respond to certain body conditions. That's also going to influence our health. Long-term stress affects our body, anxiety affects our body, but just oppositely, if we're calm and we're relaxed, we can actually change the body's responses to illness. Intellectual, this encompasses our cognitive abilities, past experiences, our educational background. So what are we able to recognize in our environment as being healthy or non-healthy? What kind of education level do we have? Were we even raised around people who valued their health? Do we even have that information to bring to the table? Whether or not we can understand the cause of a disease and the importance of a healthy lifestyle, that's going to have a huge impact on our health. Our environment, so what kind of housing situations do we have? Do we live in a clean environment? What is our climate like? Do we live downtown and we're surrounded by pollution all the time? Our access to food, what kind of food are we eating? Is it healthy food? Do we have clean running water? These are all environmental issues. Socioculture, this is our low income groups, racial and ethnic minorities, and other undeserved populations that are less likely to seek medical care to prevent illness and have fewer treatment options available to them. And they've done studies where the complete opposite of that, higher income groups are more prone to stress-related habits and illnesses, but they have access to care and they seem to partake in care. And then we have spiritual. So what are our beliefs and our values, what's important to us. This is going to affect our health beliefs and our illnesses. So if we believe that we want to be healthy and we want to have a good diet and we want to prevent disease and we work out every day, more than likely we're going to be healthy. If we don't care about those things, we probably aren't going to be healthy. So it's just important to remember that it's individual for each person. And we have to know, we can educate our patients, but we can't force other, opinions about health and stuff like that down their throat. We have to do it respectfully and keep in mind what their, ultimate choices are. So we talked about this already. Let's see. Risk factors are something that increase our chance of developing an illness or an injury. Like other components of health and illness, risk factors are often interrelated. So risk factors can be modifiable. Modifiable means these are things that a person can change, such as quitting smoking. And sometimes there's non-modifiable risk factors, things that cannot be changed. And these would be like your family histories of cancers and heart diseases, things that we can't change. So age is a risk factor. School-age children are at high risk for communicable diseases. And then after menopause, women are more likely to develop cardiovascular disease. Genetic factors, a family history of cancer or diabetes will predispose a person to developing that disease. Physiologic factors such as obesity, we know that obesity increases so many things. The possibility of heart disease, certain cancers. Pregnancy also places an increased risk on the mom and the developing baby. Healthy habits, so smoking obviously increases the probability of lung cancer. Poor nutrition can lead to all kinds of health problems, cardiovascular issues mainly. Our lifestyle, so multiple sexual relations increases our risk for sexually transmitted diseases. Events that increase stress in our life that can lead to cardiovascular issues. If we're getting divorced or if we know we have work-related pressure, that can precipitate illnesses and injuries. And then environment. So working and living environments such as hazardous materials, poor sanitation, these things can also contribute to disease. All right, so health promotion and illness prevention. Health promotion is a behavior of a person who is motivated by personal desire to increase well-being and health potential. We always see a big influx of health promotion January 1st. It's a new year. Everybody's coming off of all that bad eating throughout the holidays, and everybody is motivated by losing weight for the year, and everybody joins the gym. Health promotion is health protection is illness and disease prevention. So it is behavior motivated by a desire to avoid or detect disease or to maintain functioning within those constraints of an illness or disability so that it doesn't get any worse. And then health promotion and illness activities occur in different levels. All right, so when we think of health promotion, we have primary, secondary, and tertiary. There's 3 different levels. So primary health promotion and illness prevention are directed towards, and these next couple slides are important for you guys. I want you guys to know this. Primary health promotion and illness prevention are directed towards promoting health and preventing the development of disease or injury. So examples of primary level activities are immunization clinics. So if we're getting immunized and our children are getting immunized, we are preventing the development of disease. Family planning services, providing poison control information, again, preventing the development of a disease or an injury. Accident prevention education. We do a lot of this with younger children. And then again, when they get older and they start getting involved in a little bit riskier behavior and they start driving cars. So you see that education through those age groups. Other nursing interventions that we do, we teach patients about healthy diets. We teach patients about the importance of regular exercise. So engaging in some type of exercise for at least 30 to 45 minutes a day, 3 times a week. We educate about safety in industrial and farms. So a lot of people work in that industry and the farms, and they, that's their life and they do that every day. So we teach about how to be safe. We talk about using seat belts and then safe sex practices. So these are all promoting health and preventing injury. Health risk assessments are a very important part of that primary health promotion and preventative care. A health risk assessment is an assessment of that total person, which gives you a picture of the person and indicates areas of risk for disease or injuries. And it gives you an idea of how you can help support their health and what topics you need to educate them on. So you can see box 3-3 in your book. There's a self-test there. That you can use to, you can take for yourself if you want, and you can do it on another person if you want to practice that. Let's see. During primary prevention, teaching is going to be a very important activity. It's going to be one of the main things you do because we're preventing and promoting. Before teaching can be initiated, it's essential that the nurse engages in that patient discussion about their health risks and implications of these risks. Once the risks are identified, then the nurse can develop a patient-specific teaching strategy to help the patient address the risks. Okay, so secondary health promotion and illness prevention. That focuses on early detection of disease with prompt diagnosis and treatment of any disease state that was found. The goals of secondary prevention are to identify an illness, reverse or reduce its severity, or provide a cure and therefore return that patient to maximum health as quickly as possible. That is the goal. Examples of nursing activities at this level are assessing children for normal growth and development and encouraging regular medical, dental, and vision examinations. Other activities include blood pressure screenings, cholesterol, having skincare, following up with a dermatologist once a year to have them do that skin check, recommended gynecological examinations, mammograms for women at appropriate ages, teaching males about testicular self-examination, and then direct nursing care interventions that we would do as nurses at the secondary level include administering medications and caring for wounds. Screenings are a major activity involved in secondary health promotion. Oops. Oh my God, now I lost my spot. Okay. All right. So then we have tertiary health promotion and illness prevention. This begins after an illness is diagnosed and treated, and the goal is reducing the disability and helping rehabilitate the patient to a maximum level of functioning. Nursing activities that we do on the tertiary level include teaching a patient with diabetes how to recognize and prevent complications, maybe using physical therapy to prevent contractures in a patient who had a stroke or some type of spinal cord injury, and then referring a woman to a support group after removal of a breast because of cancer. So that's what you would see on the tertiary level. So we do have a couple different models of health and illness. So there's the health promotion model, the health belief model, the health illness continuum, and then the agent host environment. So Models of why and how people behave in ways to promote health and prevent illness help care providers understand different health-related behaviors and how we can adapt to care for these people from different economic and cultural backgrounds. So the health belief model. The health belief model focuses on what people perceive or believe to be true about themselves when it comes to their health. This model is based on 3 components of individual perceptions of a threat of a disease. So number 1 is the perceived susceptibility to a disease. So that is whether they believe that they will or will not contract a disease. Number 2 is the perceived seriousness of the disease. So this is, well, I might get it, but how serious is it? And how is it going to affect my health and my lifestyle? So what if I get it? I might just be sick for a couple of days and I'll be fine. And then the third is the perceived benefits of action. So this is the person's beliefs of how effectively measures will prevent illness. And then self-efficacy is one's belief in the ability to reach goals and complete tasks. It offers a strong influence on personal choices. So not everybody has a good belief in whether or not they can reach their goals. Some people feel like they can, some people feel like they can't. So you have to remember that when you're also caring for patients. You're not always going to find someone that is very involved in their health and has a positive outlook. The health promotion model. This model was developed by Pender. It was developed to illustrate how people interact with their environment and how they pursue their health. This model incorporates individual characteristics and experiences, as well as behavior-specific knowledge and beliefs that help motivate health-promoting behavior. There's personal, biologic, psychological, and sociocultural factors that play into this model. It incorporates age, the biological sex, a person's strength, their self-esteem, how they view their health status at the present time, how they define health, and their socioeconomic status. This model believes that all of those help predict a given health-related habit. Health-related behavior is outcome and directed towards attaining positive health outcomes and experiences throughout a person's lifespan. A client initiates a health-related behavior by committing to a plan of action, accompanied by developing associated strategies to perform the valued behavior. The health illness continuum. This is one way to conceptualize a person's level of health. This model views health as a constantly changing state based upon your environment, you, the agent, and the host. It believes that it's a constantly changing state and there are high levels of wellness and death at opposite ends of a graduated scale. So at one end is your high level of wellness and at the other end is death. And then in the middle is a continuum and you go back and forth. So the continuum illustrates that ever-changing state of health as a person adapts to change based on their internal and external environments. For example, patients with cancer may view themselves differently at different times, at different points of that continuum, depending on how well they believe they're functioning with their illness. So when you give a patient chemo, the day that they get it and maybe 2 or 3 days after, they may feel great. They have a great positive outlook. Yes, I can do this. You know, I'm going to go through these treatments and then I'm going to be fine. I'm going to beat this disease. But then as they get closer, a little bit further away from that time where they had the chemo, usually about 7 to 14 days, then they start feeling extremely bad. They get really, really sick. They're really, really tired. They miss time from work. Some patients report that they lose days at a time between the pain and sleeping. So their outlook and the way they see things on that continuum might not be so positive during that time. But then when they get past that point again, then it starts going towards health and wellness again, because they don't feel so bad, they start to feel better, and they have a more positive outlook. So that's the health illness continuum. Then we have the agent host environment model by Level and Clark. This views the interactions between an external agent, a susceptible host, and the environment. They believe that that's what causes disease in a person. It's a very traditional model that explains how certain factors place some people at risk for developing diseases. This model believes that these factors are constantly interacting with each other, and that a combination of these factors obviously increase a person's risk of illness. This model is very limited when dealing with non-infectious diseases, obviously. So this is that agent, host, and environment triangle. And they believe, this is what they believe, that everything, it's kind of like a little circle there. The host has an effect on the agent, which has an effect, the environment starts off and causes this circular action that's ever changing. All right. Which model of health and illness views health as a constantly changing state, with high level wellness and death being on opposite ends of a graduated scale?
B.
Yes, B, good job. Health illness continuum. All right, so now we're going to talk about complementary and alternative therapies. So complementary therapies are interventions that can be used with conventional medical treatments and use them together, and they complement them. Mind, body, and spirit are integrated and together influence health and illness. Health is a balance of body systems that include your mental health, your social health, your spiritual health, and of course, your physical health. These models believe that illness is a manifestation of imbalance and disharmony, and the emphasis is on health. Healing is done by the patient, and care is individualized to each patient. So what do nurses need to know about CAT? So many patients are unsatisfied with allopathic treatments. So allopathic treatments are just what we get when we go to the doctor. Because they're unsatisfied or they view them as risky, they're turning to these complementary alternative therapies. So you might see it as CAT, complementary alternative therapies, or CHA, complementary health alternatives. Both the same, both interchangeable. So some people use it in combination with their allopathic treatments, and some people just don't want any medications at all, and they're doing these alternative therapies. So patients, nurses, family members, physicians, and institutions are expecting nurses to be knowledgeable about these therapies. There's a lot of opportunities for nurses to expand their practice to meet this ever-changing need, because a lot of patients are moving towards this. There's different centers around that are just developed for these options for patients. Nurse practitioners run these programs, doctors run these programs, nurses work there. So it's in our best interest to learn about these, because we're going to see these patients come into the hospital. And we need to know how to educate them, and we need to know how this process works. So they use these as a way to promote health and manage illness. Many patients use these types of therapies as outpatients, and then they also want to continue them when they come in the hospital as inpatients, Many institutions now provide complementary therapies to inpatients as part of a total patient care. Many nurses as well are starting to expand their clinical practice by incorporating these alternative therapies. Nursing is expanding its knowledge base to include information that explains alternative therapies. For example, different pharmacology courses in schools of nursing frequently include information about herbs. We've talked about some of them in our class. There are certifications that nurses can get in basic holistic nursing care. For nurses with bachelorette degrees, and then they can also get master's degrees in what they consider advanced holistic nursing. So allopathy is that traditional medicine that we know of today. You go to the doctors, you get a prescription, that's your primary care physician, that's allopathic medicine. Holism is a theory and a philosophy that focuses on connections and interactions between parts of whole. There's a nice table in your book, table 28.1, that talks about the beliefs that are associated with these complementary and alternative therapies versus allopathic therapies. It's on page 797. You guys should take a look at that. Integrative care is a combination of allopathic and complementary and alternative modalities. I see this a lot in my hospital. So we have these outpatients, these patients in the outpatient setting who take these different alternative therapies, but they also use allopathic therapies too. And then when they come in the hospital, I see a combination of both of them. So if we look, if we have an example over between complementary alternative therapy approaches and allopathic approaches. So just in regards to the common cold. So allopathic treatment, if we were taking care of a patient with a chronic cold, that doctor would recommend rest, fluids, decongestants, over-the-counter medications. Complementary alternative therapies, they would recommend rest and fluids, but then they might, instead of giving you a decongestant or an over-the-counter medicine for that sinus issue, they might recommend acupuncture to appropriate areas to help reduce that sinus infection. So that's how things differ in that approach to treating the illness. So allopathic medicine, also called biomedicine. Health is an absence, this believes that health is the absence of disease. The main cause of illness is pathogens. Illnesses can occur in either the mind or the body. Both are separate entities. Curing an illness seeks to destroy the invading organism or repair the affected part. Emphasis is on disease and high technology. So high technology are the prescriptions that we prescribe, surgical implementations, radiation, chemotherapy, things like that. And then biotechnology, pharmaceutical approaches, and different diagnostic tools. So that's allopathic medicine. That's how we treat illness, using all of those. Holism. So holism is a theory and a philosophy that focuses on connections and interactions between parts of what's considered the whole. Some people think that holism was a recently developed system. It was not. Holism, in fact, was actually the predominant belief throughout history until a French philosopher, his name was René Descartes. He lived in the early parts of the 17th century. He asserted that the mind and the body were very separate from each other. That whole belief system lasted until the early 20th century, when researchers began to prove that there was actually a connection between the mind and the body. So theory and philosophy focuses on those connections and those interactions. And it also believes that, all organisms continuously connect and interact with their environment. It believes that parts of the organism their systems, their subsystems, or their cells are continuously interacting and changing. And a continual interaction and change in the body is not the sum of its parts. It's reduxism, which is a unified dynamic whole. Holistic nursing is a nursing practice that is built on a holistic philosophy. Healing is the whole person, and that is the goal. We want to heal that whole person, every aspect of that person. So there is a such thing as the American Holistic Nurse Association, AHNA. This association promotes the education of nurses and other healthcare professionals, and also the public in aspects of holistic caring and healing. They want nurses to explore 3 questions when they treat patients. They want you to look at yourself and ask yourself, do you know what the meaning of healing is? And if you do, what does it mean to you? What do you think it is? They want you to think about your practice and think what you can do each day to help facilitate healing for yourself and for your patients. And lastly, how can you as a nurse be an instrument in the healing process? So a nurse healer is a person who facilitates another person's growth towards wholeness. So when we say wholeness, we mean their mind, their body, and their spirit, or assist them to recover from illness or transition sometimes to a peaceful death, because that unfortunately is the alternative for some people. So in the United States, we have 30% of adults, 12% of children as of 2012 that were taking part of these alternative therapies. This is why, that was back in 2012, and I'm sure the most recent data suggests even higher. I've seen different studies that say close to 60%. So this is why we're always telling you to ask about those alternative therapies. What else are you taking? What else are you doing? You know, certain vitamins, you know, things like that. What are you taking every day? Not just prescribed medications, but other things that you buy over the counter. The reasons why people are using this alternative therapy is because they want to improve their health, they want to have a sense of well-being, or they're trying to relieve some type of symptom of an illness. Most frequently used alternative therapies that we see are supplements, not even just supplements or medications. It's deep breathing. Some people use meditation, they use yoga, they use massage. There's certain mind-body therapies that they use. Some people go to a chiropractic office on a weekly basis or a bi-weekly basis. So just remember that because so many patients are using it, it's important that the nurse asks their patient if they are using any alternative therapies. Important, important, important. All right, so the National Center for Complementary and Alternative Medicine has 10 guiding principles that they want us to look at before we issue recommendations about certain supplements and things like that. So they want us to think about the wholeness, the orientation in healthcare delivery. They want us to look at the evidence of safety and efficiency. So how efficient is it? How safe is it? Is it something that we have studies on? Is it something that only one person has tried? Is it something that they only explore in other countries that you know, have to pay a lot of money to get over here? So what do we know about it? What is the health capacity or the healing capacity of the patient that you're recommending this to? What's their health status now? You want to make sure you're having respect for individuality. So this causes you have to look and realize that what might be right for one person is not right for another person. You have the right to be able to choose the treatment. So because it's something that we try in our own life or that we've recommended to other patients that we've seen be successful, we have to understand that sometimes our patients might not be interested in that, and that's their right to be able to choose or deny a treatment. Is the medication emphasizing health promotion and self-care? Does it partner as an essential to integrated healthcare? Because you don't want people that have serious illnesses just to disregard those healthcare opportunities in that allopathic medicine. So examples of that would be some patients that have chemo. They don't want to have, that have cancer. They don't want to have chemo. They just want to try all these different things like marijuana and these special herbs. So that's not always the best way to go sometimes. So you want to present both sides. Education as fundamental healthcare service. So you have to make sure that you have education about these medications or these alternative therapies that you are discussing. And then dissemination of comprehensive and timely information. So what kind of information do we have to give them? Is this the latest and greatest? And then integral public involvement. So who else is taking this? What does the FDA say about it? What other companies are looking at this? Or, you know, if it's a cancer medicine, is this something that has been recognized by the American Cancer Association? Things like that. So these are just some guiding principles that they want us as nurses to think about before we talk about these therapies. So the FDA, we talked about this several weeks ago, is responsible for regulating dietary supplements. The FDA does not regulate all dietary supplements. There are some things that get put out on the market before they can, and sometimes they just don't give any input about certain alternative therapies. So they have developed what they call a tip-off list, which is to help consumers identify essential ripoffs. So they want you to be aware and be leery of products that seem to be a one product does it all. So you should be very suspicious about a product that claims to cure everything from blindness to heart disease. It's probably not the case. If it sounds too good to be true, it probably is. If that were the case, then we wouldn't have a lot of sick people. You want to beware of certain success stories. So products that say, it cured my diabetes or all my tumors are gone. These are easy to make up. They never take the place of scientific evidence. Quick fixes. So, you know, you can take a pill a day and lose 30 pounds a day. Well, if that was the case, nobody in the world would be obese or have health issues. We'd all be taking the pill and we would all be skinny and happy. Some things that say all natural. So they'll say on the package, all natural ingredients. These plants were found in nature's. Well, some things include poisonous mushrooms in small amounts. Well, if you have an allergy or an unfortunate reaction, it can kill you. So you want to be careful about those all natural things that can be hidden. You want to be careful with things that just come out. So those what they call miracle cures. It's a new discovery or a scientific breakthrough or a secret ingredient. It takes a long time to be able to put a label on something and know that it's effective. And conspiracy theories. So claims like if you hear some product that says that the pharmaceutical industry and the government and somebody needs to
Love line.
mute their love line.
Ouais, appelle-moi à 22h. Ouais, finis à 22h.
Love line. Mute your thing, honey.
Oh my gosh.
Thank you.
Sorry.
I don't know what I was saying. Okay. So things that say like the pharmaceutical industry and the government are working together. No, That's not true. So these are just some things that you want to be a little bit leery of. And then before you start taking any of these medications, you always want to check with your primary care physician first or your healthcare provider, just to make sure to see what they know about them. So a good example of this is I don't like to take medications anyway. And the only thing I take Celexa because I have anxiety. So I'm not even taking it for like 15 years. It's the only thing I take. Well, when I started going through menopause, I started having these terrible hot flashes, like terrible, disgusting hot flashes. So I started taking one of these Facebook groups that I follow said, start taking evening primrose oil. So I'm like, okay, I'm desperate. I'm going to start taking it. Like a lot of women said that it worked and it's been around forever. So I'm like, okay, it probably works. So I started taking it and I'm not really sure if it helped or not, or I was just progressing through menopause and it was just getting better. But then when we were doing this pharmacology class and I was going through your slides and looking at this information, there was some information in there that said that if you were taking an SSRI, that you should never take evening primrose oil because it can increase your risk of having a seizure. So I guess if I would have asked my primary care doctor, they probably would have said, stop taking that. So I stopped taking it. So just a follow-up of why it's good to always check with your primary care physician before you start taking stuff. All right, so what are the alternative therapy domains or categories? So we have whole or alternative medical systems. So these are similar to what we call Western allopathic medicine. These are complete systems of theory and practice. They consist of a set of beliefs about the origins of diseases. So where do they come from? How do they act? Who is susceptible to developing them? They also have ways to promote health and they offer different types of treatment. Then we have mind-body practices. This uses a variety of techniques that are designed to enhance the mind's ability to affect to different bodily functions and symptoms that we have. We could use yoga, meditation. You could use acupuncture, energy medicine, manipulative and body-based practices. So an example of that would be chiropractic care. Then we have energy healing, which is the theory behind that is that we're manipulating the electrical energy in our body. It's called Qi or Qi, I think it's Qi in Chinese medicine. And it believes that this electrical energy is emitted by the body's nervous system. Then we have biologically based practices, which are, they are practices in alternative therapy that use substances found in nature. So these are certain herbs, certain health foods, and certain vitamins. Then we actually have physical manipulation practices where this is your actual hands-on massages or a movement of certain painful areas. All right. So what is this? Ayurveda is balance of the mind, body, and spirit. It prevents illness and it promotes health. It originated in the Vedic civilization in India about 4,000 years ago. So it's been around for a very long time. It is considered one of the world's oldest medical systems. The aim of Ayurveda is to integrate and balance the mind, the body, and the spirit. This model looks at a connection between the universe with people, their health, and the body's constitution and different life forces. We have yoga. Yoga is mind and body practice, which comes from ancient Indian philosophy. It includes a combination of physical movements, there's breathing exercises, and different relaxation practices. The various physical positions or postures that you take during yoga that you practice are used to promote strength and flexibility. It helps increase your endurance. It does promote relaxation, and it can reduce a person's response to stress. So one of the things that we use for stroke patients is yoga. There's actually classes that you can take if you've had a stroke with these certain yoga classes. And then we also recommend yoga for our older population because it really helps build their balance as they get older. Then we have Qigong, which is a system of postures and exercises, along with breathing techniques and visualization. The majority of the exercises enhance systemic health, so overall health. They're designed to restore the healing system, the body's innate intelligence, and it believes that it knows how to correct and heal itself. Then we have acupuncture. So acupuncture consists of placing very, very thin, short, sterile needles at particular points in your body. It's believed to be where the centers of nerves and vascular tissue are that follow along a meridian. Figure 28.6 and 28.7 in your book show you a good bit of information about acupuncture. So acupuncture either increases or decreases the flow of Chi along the meridian. They believe that it restores the balance of yin and yang, and that this change is the flow of energy which contributes to healing. And a lot of people try acupuncture and a lot of people swear by it. I've seen a lot of different patients that have been successful with acupuncture. Then we have traditional Chinese medicine, which perceives humans as micro cons of the larger surrounding universe. So there's a lot of different systems out there. Shamanism is illness and other forms of distress on the bodies are thought to originate from the spirit world. So if you can rid the spirit from the body, then they believe that you'll be able to restore health again to the body. We have homeopathy, which is remedies that are derived from substances that come from plants, minerals, animals. There is not a lot of evidence to support effective treatment for certain conditions that they prove useful for. So that is important to remember. We have naturopathy, which is different treatment approaches, including certain dietary supplements. There's manipulative therapies and practitioner-guided detoxifications. And then chiropractic. So chiropractic care, the goal is correcting alignment problems. If you correct those alignment problems, you will alleviate pain, you will improve function, and then you'll be able to support the body's natural ability to heal itself. So there's different types of yoga. Ashtanga focuses on synchronizing breaths with a fast-paced series of postures. Bikram or hot yoga is done in a 105-degree studio with 26 posture sets. Then they have Iyengar, which focuses on proper alignment of the body and holding poses for a longer period of time than other yoga classes. And then Kripalu or gentle yoga, which focuses on relaxation and coming into balance. So Qigong and Tai Chi, this is a system of posture. It's a series of exercises that are both gentle and dynamic. It also incorporates certain breathing exercises that you do in various postures. And then visualization that helps regulate the Qigong. I've never heard of Qigong before, ever. I've never seen a patient that does it either. I'm sure there are. And then traditional Chinese medicine. So this is based on the yin-yang theory, the concept of two opposing yet complementary forces that help shape the world and the life. The qi is vital energy or a life force that circulates in the body through a system of different pathways called meridians. You have They also have the 8 principles, which are cold and heat, interior and exterior, excess and deficiency, and yin and yang. These are the chief principles, and they analyze symptoms and categorize conditions. The 5 elements are also included in this traditional Chinese medicine, and they are fire, earth, metal, water, and wood. And these all correspond to different organs and tissues in the body, and they help to explain how the body works. So when we talk about yin and yang, yin is very cool and moist and dark. And then yang is hot and dry and light. So this is why they believe that they complement each other, because they are the complete opposite. And then when it mixes together, it gives you the perfect mix. So acupuncture, this is where the Qi flows vertically through the body, through those 12 meridians. Different energy circuits nourish and support all of the cells and organs of the body. They place these very thin, short, sterile needles at different particular acupoints along that meridian. When that happens, it changes the flow of energy and helps restore the balance of yin and yang. These practices are believed to reduce pain. I've seen cancer patients that go to acupuncture, patients that have diabetes that go to acupuncture, people go for migraines, for back issues. It promotes adherence to substance abuse programs, minimizes nausea and vomiting due to chemotherapy and pregnancy. So these are those meridians, those little blue lines. And each one of those blue lines, anyone that's trained in acupuncture knows exactly what those points mean and what's affected. That's not something that we have to know. I just wanted to be able to show you what those meridians look like through the body. And then we have chiropractic medicine. So doctors of chiropractic medicine are licensed. They attend a 4-year degree program of chiropractic school. They do spinal adjustments. They can apply heat and ice. They do various forms of electrical stimulation. They offer a variety of different relaxation techniques. They do rehabilitative and then offer just general exercise. They can counsel you about maintaining a healthy diet, programs that offer weight loss, and making other lifestyle factor changes. And they can also recommend dietary supplements. So mind-body modalities, we can use relaxation techniques through breathing. We can use meditation. We can use guided imagery. We can use prayer. So when prayer is included in the definition of alternative therapies, the domain of mind and body medicine is the most commonly used domain. We also have aromatherapy. This uses essential oils of different plants as therapy to improve your physical being, your emotional being, and spiritual as well. So an example would be that some people use ginger or peppermint for nausea and lavender and chamomile for insomnia. And this is actually something that our hospital does. Every unit has an aromatherapy machine at the nurses' station. And they come by every month and fill our box up with all these different aromatherapy scents. And we always have them going on each unit, 24 hours a day. So what are the benefits of being able to relax? Well, it helps reduce our anxiety. It helps reduce muscle tension and pain that's caused by anxiety and stress. It improves function of our immune system. It enhances sleep and rest, and it improves the sense of well-being. So if we're stressed out and we're running ragged, the perfect example is, nursing students. When you're in nursing school, the first couple of weeks you're fine, but after a month or two, you're going to notice that you can probably associate with this now. You're tired. You're more susceptible to developing a cold. You may have different aches and pains that you didn't realize you had before. So being anxious and stress causes pain, muscle tension, and it wears down your immune system. So those are the benefits of relaxation. Different energy medicine modalities that we can use. We can use therapeutic touch. So this is important. I want you guys to know this. Therapeutic touch is the use of our hands on or near the body with the intent of helping or healing someone. The therapeutic touch process consists of centering and assessing the energy field and rebalancing the field using modulation, which they consider unruffling, and other techniques. Therapeutic touch is based on 4 therapeutic premises. That is that a human being is an open energy system, and anatomically, a human being is bilaterally symmetrical. It believes that illness is an imbalance in an individual's energy field, and that humans have a natural ability to transform and transcend conditions of living. So sometimes you use therapeutic touch when you have a patient. Maybe you have a patient who's going to have a biopsy for, maybe she has a breast tumor and she's really nervous and she's anxious and she's crying, and you see that when you go into the room. Well, you might go in, you might sit at the end of the bed, you might hold her hand, you might put your hand on her shoulder. Those are examples of therapeutic touch. And you'll know if your therapeutic touch has been helpful because they're going to tell you that they feel better now, or they seem less anxious, or they're not as upset. So just that little touch, can really help your patients, and it makes them really feel like you care about them, you're listening to them, and you understand what they're going through. So healing therapeutic touch. Healing touch is a collection of energy techniques used to assess and treat the human energy system. Through assessing and treating the energy system, it affects our physical, emotional, mental, and spiritual health and healing. The goal of healing touch is to restore wholeness through harmony and balance, and to enhance the person's ability to self-heal, restore wholeness through harmony and balance. So some benefits of this: it's non-invasive, it is effective, and it's non-toxic and economical. It's free. All right. Ayurveda is medicine to integrate the balance of mind, body, and spirit. The key concepts of this include universal interconnectedness with people, their health, and the universe. And they believe that the body's constitution and life forces all work together. So we said earlier, it originated in the Vedic civilization in India, some 4,000 years ago. It brings balance among people, the environment, and that larger cosmos, which they believe is integral to health. The central is patient's basic constitution. So this talks about the dasha, the Veda, the Pitta, and the Kapha. So the dashas are the Vata, the Pitta, and the Kapha all together. That's what we consider a dasha. It's one of the most foundational concepts in this belief system. The dashas are energetic forces of nature. They are functional principles that help us understand ourselves better and the world around us. So Vata is characterized by the mobile nature of wind and air. It's the wind and air energy. Pitta embodies the transformative nature of the fire energy, and Kapha reflects the binding nature of water. So air, fire, and water. They use those concepts together, and these practitioners will prescribe individualized treatment plans that include different metals mixed with herbs, minerals. They do recommend diet and exercise, and they also recommend certain individualized lifestyle recommendations. Shamanism is the most widely practiced medical system on our planet. Illness and other forms of distress are thought to originate in the spirit world. The shaman or the medicine man, or sometimes the medicine woman, possess the ability to access the spirit world, which is done on behalf of people or a community as a whole, and it helps to return to ordinary reality. Either by offering information or providing proper treatment. Treatment can consist of retrieving lost soul energy, restoring that person to the right relationship with the spirit world, and treating the symptoms that they're having. General healing techniques involve different plants and herbs, some animals, rituals. They also do different ceremonies and purification techniques. And theories of homeopathy. All right, so homeopathic medicine and treatment has been around for about 200 years. This approach to dealing with illness is frequently used to suppress symptoms. So when we have a fever, we give acetaminophen. Homeopathic medicine or homeopaths believe that when symptoms are suppressed in this manner, that they don't actually cure them, or they don't actually get rid of the fever, that the body actually, that it just suppresses it and it goes deeper inside the body, making it ultimately more difficult to cure because it's not ridding the body of it altogether. So supporters of homeopathic medicine point to two unconventional theories. They believe that like cures like, and that the notion that a disease can only be cured by a substance that produces similar symptoms in healthy people. And then they also believe the law of minimum dose. So this is the notion that the lower dose of a medication is greater in effectiveness. So if you were giving 350 milligrams of Tylenol, they would ultimately believe that you only need 125 milligrams, and that would be greater than the 350. Many of the homeopathic remedies that they give are diluted so that no molecules of the original substance do remain. Naturopathy has evolved from very traditional practices and healthcare approaches that were popular back in the 19th centuries in Europe. They believe that health is a dynamic state of being that provides an abundant amount of energy for people to deal with life in our complex society. Naturopathic practitioners use many different treatment approaches. They use dietary and lifestyle changes. They implement stress reduction techniques. They also recommend certain herbs and other dietary supplements. They do also offer some manipulative therapies and practitioner-guided detoxifications. So the principles of this treatment program is that they first do no harm. So they want to give maybe a certain herbal supplement or some type of treatment modality, but it can't cause any harm. So that's what they think about first. The physician is not just the doctor, they're a teacher. They're there to educate. They have to treat the person as a whole person. Their goal is prevention. They want to prevent things from occurring. They believe in a healing power of nature. So that's why so many of the dietary and herbal supplements come from nature. And then they are treating the actual cause of what's causing all the problems. Then we have botanicals or herbs and nutritional supplements. So the FDA and the Institute of Medicine recommend science-based evaluation. Nurses need to be able to provide safety education for their use. So some herbs can be used for treatment of disease and reduction of symptoms, but we have to be able to understand the education surrounding them, and we have to know if they are safe or not. They also offer nutritional therapy, so therapies that can help increase your traditional nutritional deficits. And then natural. So natural does not mean safe. People think that all the time. It's all natural. Well, it must be safe. So for example, some people use ginkgo. It's been known for many, many, many years to help to improve memory, but it also affects platelet function and should not be used with people who are using warfarin or aspirin. So patients that take warfarin or aspirin, they're taking it because they have an issue with their clotting factors. And their clotting factors get too thick, so they get blood clots. So we put them on warfarin or a high dose aspirin, and it helps thin their blood. So then if they take the ginkgo, it has the opposite effect, and it can interfere with that. So just because it's natural does not mean that it's always safe. And laughter. So you've heard people say that laughter is the best medicine. Laughter increases serotonin and endorphins in the brain. It helps replenish the lungs. It relaxes your muscles and helps ease tensions in the body. It reduces stress hormones in the body. It helps protect the heart, increases our immune system functioning, and is considered the best workout. So we should incorporate more laughing into our life. All right, guys, that was health promotion. Do you guys want to take a 5-minute break? Okay, objectives. We are going to describe the nursing management for a patient with degenerative joint disease, identify risk factors for the development of osteoporosis, explain the nursing management for a patient undergoing a joint replacement, identify the stages of bone healing after a fracture, describe the signs and symptoms of a fracture, explain the nursing management for patients with various types of fractures, and describe the potential complications associated with a fractured hip. So this is just a little review of anatomy and physiology. I'm not going to spend a lot of time on this because you guys already know this. You've had this information. So when we think about our bones, the human body has 206 bones. All of our skeleton bones are classified. They're either short bones, so those are your fingers and toes, long bones that you find in your femur or your ulna, your flat bones, which are in your sternum, and then you have your irregular bones. Those are the ones like you would see in your vertebrae. There are 2 types of bony tissue. So the first is calcaneus tissue, or spongy bone. That is a light type of a bone, and it has a lot of different spaces in it. The second is cortical bone, which is a more compact bone and is very dense and hard. Both of these types are found in varying amounts through all of our bones. Our bone is composed of many different cells. There's also a protein matrix in there and various mineral deposits. When we talk about our bone cells, there are 3 types. So we have our osteoblasts. The osteoblasts build bone. We have our osteocytes. So as those osteoblasts are starting to transform into mature cells, they're called osteocytes. And then we have osteoclasts, which are the cells involved in that destruction, resorption, and remodeling of bone. So those are the 3 bone cells: osteoblasts, osteocytes, and osteoclasts. Inside the bones are 2 types of bone marrow. We have red bone marrow and yellow bone marrow. Red bone marrow is usually found in your sternum, in your ilium, in your vertebrae, and in your ribs. The red bone marrow is responsible for manufacturing your blood cells and your hemoglobin. Long bones have yellow bone marrow, which consists of fat cells and connective tissue. If our blood cell supply becomes compromised, the yellow marrow will take on the characteristics of the red marrow and begin producing blood cells, which is pretty cool. All right, so when we talk about our muscles, we have three types of muscles: skeletal, smooth, and cardiac. So our skeletal muscles are found in our voluntary muscles. Our smooth muscle is found in our involuntary muscles. So that's the stomach, the intestines, the blood vessels, and the ureters. And then the cardiac is involuntary muscles also. When we talk about our joints, a joint is a junction between two or more bones. Most of our skeletal joints are made up of free moving joints or diarthrodial joints. Diarthrodial joints are a junction or a union, or found at a junction or a union of two bones, which allow our body to make certain movements. We have tendons, which are cord-like structures that attach to our muscles, and they attach our muscles to the periosteum of the bone. Muscles have two or more attachments. One is called the origin, which is more fixed in place. The other is called the insertion, and that one is more movable. When a muscle contracts, both attachments are pulled and the insertion is drawn closer to the origin. Ligaments. We have a lot of different ligaments in our body. They consist of fibrous tissue that connect two adjacent freely movable bones. They act as a stabilizer to help protect our joints. We also have cartilage, which is a firm, dense type of connective tissue. The primary functions of our cartilage are to help reduce that friction between different articular surfaces. It also serves as a shock absorber, and it helps reduce the stress on our joint surfaces. We have a couple different types of cartilage. There's hyaline or articular cartilage. We have costal, semilunar, fibrous, and elastic. And then we have bursa. So a bursa is a small sac filled with synovial fluid. Bursa serves to reduce friction between areas such as a tendon and a bone, or a tendon and a ligament. Sometimes you might hear patients say they suffer from bursitis. So this is when those little sacs in those areas become inflamed. So degenerative joint disease. This is also referred to as osteoarthritis. You will see a lot of patients in the hospital that suffer from this. It is the most common form of arthritis, and it can be explained basically, they call it a wear and tear disease that affects our joints in the body that we use repeatedly for work. It is a disorder that is characterized by progressive deterioration of that articular cartilage. It is a non-inflammatory, unless it's localized, and it's non-systemic. So when we're comparing rheumatoid arthritis to osteoarthritis, it has no remissions or systemic symptoms such as that fever or malaise. So that's the differences. How does a person get osteoarthritis? What happens is there's an accumulation of a lifetime of that repeated trauma that over time leads to certain degenerative changes. The most common area that we see osteoarthritis is in patients' hips, their knees, their spine, and then the different joints in their hands. As that cartilage starts to wear away, that space in that joint gets smaller and smaller, and then those two bone surfaces come closer together, and then they, in some cases, can actually rub together, and then you'll have bone on bone. The body does try to repair the damaged surface. It tries to develop new bone, which then develops in the form of bone spurs, bone cysts, or what they call osteophytes. When those new bone areas form, it's going to cause those margins in the joints to become extended. It will also cause the joints to be deformed, and then this causes the patient to experience pain, and then ultimately limited movement in those joints. So what kind of signs and symptoms will our patients have? So they might say, this is going to be a chronic pain. So we talked about acute pain and chronic pain. This is going to be a chronic pain. Your joint may hurt during a movement, a particular movement, or after a movement. You want to observe your patients for muscle atrophy, loss of function, or a limp when walking, or any restrictive activity due to pain. So your patients might say, well, you know, I used to walk 5 miles every day and I just can't do it. My knees can't take it anymore. Or, you know, I used to be able to do more things around the house, but I can't. I can't even open, you know, certain bottles because my hands hurt so bad, or I have to sleep every night with a heat pack because my back hurts so bad. These are the kind of things that your patients will say. They might show tender. They might say that they have tenderness. Their joints may feel tender. They may hurt even when you touch them, even if you apply light pressure. They might be stiff. This is one of the most noticeable symptoms that we see. It's very, very prominent at the end of the day and when they first wake up in the morning, or after a period of inactivity. So even if they take a little nap during the day, when they get up, they're really stiff. They have a hard time getting moving. They might notice a loss of flexibility, so they might not be able to move through their joints complete range of motion like they used to. Some patients might say they have a grating sensation, so you might hear or feel like it just sounds like a grater when those two joints rub together. It just sounds like it's a very loud, like screechy type of a noise. And then you might hear crepitus, which is cracking in one or more of those affected joints. Some patients might have bone spurs. Those are those little extra bits of bone that develop when the bone's trying to regenerate new bone. If you feel it in a patient, they feel like very hard lumps, and they might even completely form around the affected joint. We have Heberden's nodes, which are enlarged at the distal interphalangeal joints. And then we have Bouchard's nodes, which are located at the proximal interphalangeal joints. These can be inflamed and painful. So I had a picture, but I guess you guys don't have it. Okay, I'll have to show it to you at the end. There is one picture down here that has it. So how do we, some diagnostic findings and medical management. So osteoarthritis comes from repeated trauma and that degenerative joint changes. We can diagnose osteoarthritis by an X-ray, which is going to show disruption of that joint cartilage and different bony changes. We can do an MRI, which provides detailed images of those bones. It can show the cartilage and all that surrounding tissue. We could use a CT scan, and we can also use a nuclear bone scan. Medical management, so we recommend rest of the affected joints. They can do heat application. If it's an obese patient, we recommend weight loss because we know that when we're obese, that it's a lot of wear and tear on our joints and our bones. So if we lose weight, it might help with the symptoms. Different splints and braces can help to provide relief and maybe even prevent further destruction of those joints. Joining an exercise program is always helpful. Clients should be encouraged not to engage in activity that's going to place excessive stress on those affected joints. For medication, we offer, we tell them to take acetaminophen or anti-inflammatory drugs. So that's your NSAIDs, your naproxen, your ibuprofen. It's important that you guys understand that these medications do not prevent or cure osteoarthritis. They just help relieve the symptoms. Sometimes patients can get corticosteroids. They can be directly injected into those acutely inflamed joints. Sometimes it's successful, sometimes it's not. We don't want to prescribe narcotics to these patients. Why do you think we don't want to prescribe narcotics?
Put them at risk for falls, maybe?
Yep, it will put them at a risk for falls.
It's a chronic disease, so if you're giving a narcotic, it could be addictive and not good for them because they'll continuously have to take it. It's not going to get better.
Yes, very good. This is a chronic disease, and we don't want our patients to get addicted to the narcotics. So that's why we don't want to prescribe narcotics. There's something called supplementation, which is an injection in the it's called intra-articulation injection. They use hyaluronic acid, which helps improve that cartilage breakdown. And then if nothing has been successful and it's deemed necessary, there's possible surgical management where they would just go in and actually replace the joint through surgery. So health promotion and disease prevention. So we can encourage the patient to maintain a healthy weight. That's going to decrease that joint degeneration of the hips and the knees. We want to recommend that the patient stop smoking to reduce cartilage loss, especially if there's a family history of osteoarthritis. So there are direct links. Studies show that people who smoke cigarettes are like 72% chance greater of developing osteoarthritis than regular people that don't smoke. You want to encourage the patient to avoid or limit repetitive strain on joints. So this would be activities such as jogging, contact sports, risk-taking activities. We want to recommend that they wear well-fitted shoes with support because that's going to help to prevent falls. So risk factors for developing osteoarthritis. So the majority of adults over 60 have joints changes that can be reflected on an x-ray. So age definitely has something to do with it, over 60. Joint injury due to acute or repetitive stress on joints predisposes a person to developing osteoarthritis later in life. Obesity, we know, affects those bearing joints such as your knees and hips. It's very hard on those joints. And then there are certain metabolic disorders such as diabetes, blood disorders such as sickle cell also predispose patients to developing joint degeneration. So just something to keep in mind when you're talking to your patient and you're recommending things for them to take at home. You can always recommend for them to take NSAIDs, but you also want to ask about PPIs, which people can take over the counter for the use of heartburn. So NSAIDs and salicylates can cause, we talked about this in pharmacology, they can cause a lot of gastric distress. So with those PPIs, those proton pump inhibitors, they're available over the counter. The client may use these to help GI problems. And there is a direct correlation, studies are showing now that there's a correlation between patients who take PPIs and decreased bone density. So we don't recommend a lot of PPIs or certain PPIs as you start to get older because they think that it helps move along that process even quicker and that you lose more bone. So that's just something to be aware of. All right, so what are some nursing diagnoses that we might see for our patients that have osteoarthritis? So impaired walking related to inflammation and damage to the joints. We might see activity intolerance, right? Because they're not doing as much as they used to do because it hurts. So activity intolerance related to chronic pain, fatigue, and weakness. Disturbed body image related to joint impairment because those joints, sometimes they swell up and they get these nodules. This next slide is going to show you. Chronic pain related to progression of joint deterioration. And then self-care deficit related to pain with movement and damage to joints. So you can see these nodules here in the finger. You can see that it's a little bit red there. So that's where that disturbed body image would come into play. And this is just that cartilage there, how it wears, and the bone, how it wears the bone, how it wears down, not the cartilage. All right, so this is osteoarthritis with an osteoarthritic spine versus a normal spine. So if you look at the normal spine here, You see how the bone looks great? Look over here, how these bones have these little pointed edges. They are all bone spurs. That happens when the bone tries to remodel itself. And then look in between all of these vertebrae here. Over here, we have that nice pink, like fluffy filled disc in there that helps serve as a shock absorber between those two bones. But over here, you can see that they're losing their fluid. And then right here is actual bone to bone. So this is why a lot of people complain about back pain. So that's a good example. And this is an actual joint. So here is the capsule that helps surround your joint. In a normal person, it is pretty thin over here. It's very, very swollen. Your synovial membrane here, again, very thin. Over here, very filled, extra fluid inside of there. You can see these little bony cysts in here. You can see the degeneration of that articular cartilage. It's nice and pink and filled in right here. Over here, there's hardly any of it. You have little osteophytes here. So you can definitely see the differences between normal and osteoarthritis. This is the stages of osteoarthritis. So you have, this is what normal bones look like. This is osteoporosis, and then this is severe osteoporosis. So this shows you exactly why these older population of people are so susceptible to those broken bones, right? It doesn't take much. So this is the process of osteoporosis. So this is a 50-year-old. And I find that a little offensive since I'm 50 and I certainly don't dress like that, but this is an older book, I guess. This is a 50-year-old. And you can see she's standing up pretty straight and tall, but as she gets older, from 60 to 65 to 70, you can see how her spine starts to curve. And she gets that kyphosis right there. So that is the process of osteoporosis. Or osteoarthritis. No, that was osteoporosis. Okay, so what is the pathophysiology? So when we're young, the bone formation and resorption occurs at a very even pattern. With osteoporosis, the bone loss exceeds the bone formation. So we lose way more bone than we can ever form. The total bone mass and density is greatly reduced, which results in bones that become progressively porous, brittle, and then very fragile, leaving us susceptible to fractures and broken bones. The aging process contributes to osteoporosis. So what happens as we get older? It's a couple different things. So our level of calcitonin in the body starts to decrease. We need calcitonin to inhibit that bone resorption and then promote bone formation. But as we get older, it starts to decrease. Our levels of estrogen decrease. Estrogen is needed to inhibit bone breakdown. So this is why in postmenopausal women, they lose so much bone. It happens it's a very quick process. Once they are like 1 year past getting a period and they're considered in menopause, this bone loss process escalates in women. It's very, very quick. And then lastly, our levels of parathyroid hormone increase as we get older. So the parathyroid hormone increases bone reabsorption. So if that hormone increases as we get older, we're just going to reabsorb more bone, which is not what we want. So the etiology of osteoporosis. Well, if you have a family history, then you obviously are more susceptible to it. Females of female gender with thin, lean body builds are more at risk. White women are at the greatest risk out of anyone. Asian women are at risk who are menopausal. And African American women also have a greater risk because they have greater bone density and are less susceptible. So African American women are the least susceptible. I said that the wrong way because of their higher amount of bone density. Men have an increased bone mass, and they don't have hormonal changes as many, so they don't require osteoporosis treatment because they don't usually develop osteoporosis. If you have a chronic low calcium intake, if you take excessive amounts of caffeine, if you smoke cigarettes, if you have a history of Cushing's syndrome, if you've had prolonged use of high doses of corticosteroids. So what disease might a patient have throughout their life, even from a child even into adulthood, that would subject them to taking corticosteroids a lot for that condition?
Thyroid issues?
Yep, could be thyroid issues. I'm thinking of something else though, something that has to do with breathing.
Asthma.
Yes, asthma. So those patients that have asthma, that's really the main way that we keep their exacerbations under control and how we prevent exacerbations. They have those corticosteroids, so they are at a high risk of developing osteoporosis. Patients that have hyperthyroidism or hyperparathyroidism, patients with certain eating disorders, because then again, that calcium intake is affected. Patients with renal or liver failure, high alcohol intake, which is 3 or more drinks a day, and then deficiency in vitamin D and calcium. So our bodies don't make vitamin D, so we have to get vitamin D from other sources. Patients who have gastric bypass surgery, they're at a huge risk because when they do that bypass, they bypass the duodenum, and the duodenum is where the majority of calcium is absorbed. So that whole process is completely bypassed. And then a lack of physical activity or prolonged immobility. Bone formation is improved with regular exercise that involves resistance and low impact activities. All right, so assessment findings. Clients with osteoporosis frequently complain of lumbosacral pain. They also complain of thoracic back pain or maybe both. There is bone pain and tenderness, which results from these tiny compression fractures in the vertebrae. So they're not actual like big fractures, they're just tiny compressions, little tiny lines. They may have progressive kyphosis, which is going to result in a loss of height. They can have acute back pain after lifting or bending. It's always going to be worse with activity, and they're going to report that it's relieved with rest, which completely makes sense. They're going to have restriction in movement and maybe a spinal deformity. Graphic examinations, so your MRIs, your CTs, X-rays are going to show bone loss once it's at 25% or more. Bone loss less than 25% is not usually visible on an X-ray. They might report a history of fractures where I broke my wrist and then a couple months later I broke my femur, or I have, I broke my thoracic, some bone in my spine. They could have bone deformities, so that kyphosis and lordosis, and then pathological fractures in those long bones. So a DEXA scan is a bone scan that measures bone mineral density. And you do start having that at a certain age, and you should have it every 5 years. Usually we start at around 60, and we do it every 5 years. And that bases how we're going to treat patients with osteoporosis. And it shows us if you're at risk for it. So what is the medical and nursing management? So it is believed that if you have a diet rich in calcium and vitamin D throughout life, that you can prevent osteoporosis. Osteoporosis cannot be treated directly, but medical management is geared towards slowing that rate of bone reabsorption. Bone pain or tenderness, we can treat with mild analgesics. We can recommend that our patients take oral calcium preparations. So there's all kinds of different ones. So there's calcium gluconate, calcium lactate, calcium carbonate, dibasic calcium phosphonate. There's all kinds of different ones that your healthcare provider can prescribe. Some of these preparations also contain vitamin D, which is needed to help the absorption of calcium in the intestine. Vitamin D supplementation in your foods and outdoor activity can help. It's recommended that 15 minutes in the sun each day can give you the adequate amount of vitamin D that you need. Gearing your exercise programs towards that resistance training and that low impact activity is going to help with that bone formation. You can recommend that patients go to physical therapy. It can help reduce their back pain. It'll help improve their posture, and it will also improve their balance, which will help their risk of falls. Most of the hip fractures that we see are due to osteoporosis. We need to emphasize in our patients the need for a nutritious, well-balanced diet that is high in calcium, vitamin D, and protein. All of these are recommended to delay or prevent osteoporosis. We should be advising women to drink 3 glasses of milk daily or eat other daily products to help attain that 1,000 to 1,500 milligram of calcium that's needed daily. And those who smoke cigarettes actually require more. Patients can also drink orange juice that's fortified with calcium. That is also another good alternative. Recommending that activity that promotes bone formation. So we said that regular weight-bearing aerobic activity exercise, so even walking 45 minutes to an hour a day is helpful. You want to encourage the client to include things in their diet that are high in calcium. So those green leafy vegetables, fortified orange juice and cereals, red and white beans, figs. Vitamin D is going to be in fish, your egg yolks, your fortified milk, and different cereals. You want to have a diet rich in fruits and vegetables. These provide vitamin K, magnesium, and potassium, which are all nutrients that are known to help maintain bone density. I said earlier, it is possible to fulfill that vitamin D requirement by taking a 15-minute walk in the sun daily or just sitting outside in the sun. Encourage the client to limit the amount of carbonated beverages because carbonated beverages contain a lot of phosphates, and phosphates can cause calcium loss. And then again, those weight-bearing exercises, walking and lifting light weights. So what are some nursing diagnoses we would see? Deficient knowledge related to diet, exercise, and the need to abstain from alcohol and nicotine. Impaired physical mobility related to pain and skeletal changes. Imbalanced nutrition, less than the body requirements related to inadequate intake of calcium and vitamin D, acute pain related to fracture or muscle spasms, risk for injury, fracture. Risk factors could be lack of activity, risk of falling resulting from environmental hazards, neuromuscular disorders, diminished senses, and then risk for powerlessness because they have a debilitating disease. All right, so now we're going to talk about fractures. So a fractured bone or other injury can potentially cause dysfunction, not only to the bone, but then that surrounding muscle and injury to those blood vessels and nerves. Fractures occur secondary to trauma, which is the most common, or a pathological condition. So your patients that have metastatic cancer that has spread to their bones, or osteoporosis or Paget's disease. So Paget's disease is a disease of the bone which interferes with your body's normal recycling process, in which that new bone, remember we said that new bone replaces the old bone. That doesn't happen with Paget's disease. So those would be your pathological conditions. A fracture is a break in the continuity of a bone secondary to trauma or pathological condition. Fractures may affect those tissues or organs near the bones as well. We classify our fractures based upon the type and the extent. The loss of function, deformity, they can cause crepitus, it can cause edema, it can cause bleeding, it can cause muscle spasms, and then tissue and nerve damage. And how do we diagnose a fracture? Usually by a CT scan, just an X-ray, bone scan, or an MRI. So these are all the different types of, well, not all of them. You can have an avulsion fracture, which is a pulling away of a fragment of a bone by a ligament or a tendon that it's attached to. These are all in your book. You can have a comminuted fracture, a compound fracture, a compression fracture, which we talked about in these other disease states, which is a fracture in which the bone has been compressed. We usually see these in those vertebral fractures. You can have a green stick fracture. You see this a lot of times with children who play sports, a fracture in which one side of the bone is broken, but the other side is bent. A pathologic fracture occurs through an area of diseased bone. So it's very common that sometimes it'll happen in the hips or the femur. So I remember one time I was caring for a patient and she had metastatic breast cancer that spread to her bones. And she was reporting such bad pain in her legs. So they took her for an MRI and her entire femur was covered in metastatic disease, to the point where it wasn't, we knew that if she even tried to stand up, that her femur was just going to rupture. So she was on complete bed rest. We had to be extremely careful how we were moving her, because it could have been a dangerous situation. A simple fracture is a fracture that remains contained. It doesn't break the skin. A spiral fracture, which is a fracture that twists around the shaft of a bone. So you can go in your book and you can look at all the different types of fractures that there are. Signs and symptoms of a fracture are always going to depend on the type and the location. So pain, most patients report pain. That's one of the most consistent symptoms that we see with a fracture. It can be mild, it can be severe. The patient may attempt to move a part of the body, which contributes to increased pain. They might have loss of function. So that skeletal muscular function is going to depend on whether or not that bone is intact. You might have deformity. So a break may cause an extremity to bend backwards. I think we've all seen those gruesome pictures, especially of those basketball players that land the wrong way, or football players and their arms or legs are completely bent the opposite way. False motion. So this is unnatural motion that occurs at the site of a fracture. Crepitus is that grating sound of bone ends that move over another bone, and we can actually hear it. Sometimes it can be a popping sound, it can be a grating sound. What happens when that air gets trapped in that soft tissue area? And we might see edema, which is swelling right over that area of the fracture. We might see muscle spasms. So muscles near fractures start to just contract involuntarily. They also have spasm, which accounts for some of the pain. It may cause a limb to shorten when the fracture is involved in a long bone because of that pulling sensation of the muscle. And then if a sharp bone fragments happen to tear through surrounding soft tissue, there can be bleeding. And black and blue discoloration of that area. And then if a nerve is actually damaged, then you might see your patient has some type of paralysis, or they might have numbness and tingling. So this is the process of bone healing. So immediately after a bone fracture occurs, blood is going to pull and seep into that area, and a hematoma, which is also a blood clot, is going to begin to form. After about a week, those osteoblasts form as that clot starts to retract. After about 3 weeks, a procallus forms and starts to stabilize that fracture. A callus within the bone cell will begin to form in about 6 to 12 weeks. And then in about 3 to 4 months, those osteoblasts begin to remodel that fracture site. If the fractured bone has been accurately aligned during that healing, remodeling will be complete in about 12 months. So a fracture takes about a good year to actually completely heal. So our goal is to reestablish functional continuity of that bone. So treatment of fractures include a variety of different methods. You can use traction, and this all depends on the degree of the fracture and where it is. So you can use traction, you can use closed or open reduction, you can use internal or external fixation, or you can use the application of a cast. So the treatment method, again, depends on many factors, including the first aid that is given at the time it happens, the location, the severity of the break, the age of the patient. I always want to think about the age of the patient, especially when it's an older person, and the overall physical condition of the patient. So for nursing management, we are going to be assessing for neurovascular and systemic complications. So if you have a patient that had a hip fracture and they get a hip replacement, what do you think we're going to be monitoring?
Pain.
Pain. We're going to be monitoring pain, but what else? What could go wrong? What do you think could go wrong?
With somebody who's older?
Anybody?
Well, I was going to say in an older patient that if they had a hip fracture, they may never be able to get up and fully function again.
Yes, that is true. That is a very deciding factor for some patients. Remember, we talked about that a couple of weeks ago, how things just escalate and then they just continue on this continuum of things getting worse and worse and worse. But
Vital signs.
Say that again?
Vital signs.
Yes, vital signs. What are we going to be looking for in our vital signs?
Elevated blood pressure, temperature, if they have a fever.
Yes. So why do we want to know about a fever?
Infection.
Skin breakdown.
Infection. Yes.
And wound.
Yep, and wounds. So if we're looking at their pulse, what could, if they had a tachycardic, if their heart rate was elevated and they were tachycardic, what could that signal?
Circulation.
Say that again.
Circulation, blood circulation.
Lack of blood circulation, yes. So when we talk about assessing for neurovascular and systemic complications, so if their heart rate was elevated, it could be a blood clot, right? We know that patients that are not moving and who have had different surgeries, when they go under anesthesia, we put everything to sleep, everything. Not just the patient, the blood goes to sleep. So it's not circulating like it was before. The bowels go to sleep, which is why they're constipated. And it takes a while to get things going. So these patients are at an increased risk for developing a blood clot. But if they're having a hip replacement or a knee replacement, we're going to be doing those neurovascular assessments every 4 hours. We want to look at those pulses, right? Because we want to make sure that nothing was compromised during the surgery. So we're going to be looking at those pedal pulses, those posterior tibial pulses, those popliteal pulses. We actually have the femoral pulses as well. So you're going to be doing those neurovascular assessments, looking at that skin color. If you have a patient who had a hip replacement or a knee replacement and you go in and you don't find a pulse and that skin is pale or blue, that is a problem. That's going to signal you that, hey, this is not getting proper circulation, there's something going on. So when we have these patients that have these replacements or they have these fractures, like on the orthopedic floors, you're always doing these neuro checks every 4 hours because you want to prevent, and recognize things early. You want to provide comfort measures. So comfort measures includes elevating that extremity, giving them ice, administering those analgesics. We're going to help them with their ADLs because they're going to need help getting around. We want to prevent constipation. So why are they at risk for developing constipation?
Because of the pain medication.
Yes,
And they're immobile.
and they're immobile. You got it. Good job, girls. So they're not moving around. They don't have that, that good motility moving through them. They just had anesthesia, right? Anesthesia puts everything to sleep, including the bowels, and we're probably giving them narcotics. You want to maintain that skin integrity. They've had a surgical incision there probably. If they've had some type of replacement, they will have one. You want to look at that skin, make sure that it's healing, make sure there's no redness or swelling or any kind of purulent drainage that would signal an infection. And then you want to promote physical mobility. So we want these patients to be able to go back to their quality of living that they had before this fracture or this injury. So we're going to have them seen by physical therapy. We're going to have them seen by occupational therapy. We want to recognize, we want to think about what's going to happen when they go home. Does this patient that just had a hip replacement is she 87 years old and she used to live by herself? Well, maybe she can't go home by herself. So what kind of questions would you guys ask Mrs. Jones if she was, just say she was 76 years old and she fell at home and she had broke her hip and now she had a replacement and she wants to go back home to her house. What kind of questions would you ask her? What do you want to know?
Do you have steps?
Yes. How many steps do you have? Do you live on one floor? What else?
Family to help, anyone to help you.
Yes.
When you first get out, any type of caregiver.
Yes, because we want them to be successful when they go home. If their bedroom is on the second floor and their kitchen is in the basement for some reason, then that's going to be an issue for them. We want to make sure that they have what they need at home to be mobile and be independent. Do they need a walker? Do they have a cane now? Do they need like one of them little, motor scooter things? So you want to talk to social work and make sure that they have all the things that they need. These are all the things that the nurse is doing. They have a very important role. All right, so complications. So sometimes we might see shock or hypovolemic shock, which is related to blood loss, because remember we said sometimes you could have a break in a bone that could damage an artery or something like that. We see that sometimes with patients who have femur breaks and they cut into that femoral artery and then they bleed to death. So that hypovolemic shock, blood loss, or that loss of extracellular fluid can occur when there's damaged tissue. And if we leave these things untreated, then obviously the patient's condition is going to deteriorate. So if you do have a patient that is exhibiting this blood loss from whatever reason, we would want to administer blood and then give them fluid volume replacements. Pulmonary embolism. So this is a thromboembolism that can occur, a blood clot, after that fracture or surgery to repair fractures. Well, we said that these patients, we give them anesthesia, everything goes to sleep, even the blood. They're not moving around anymore. Certain cancers give them, thicken their blood and cause them to be more susceptible to blood clots. So all these things in conjunction, these patients are at risk for developing a blood clot, which can lead to a pulmonary embolism, which can be fatal. So we are going to, how can we prevent pulmonary embolisms or thromboembolisms in our patients? What can we do?
Keep the patient moving.
Yes, TED stockings. What else?
Elevating the legs, the feet.
Yep, elevating the legs, elevating the feet. What does that do?
To help with the circulation. for the blood to go back.
Gets that blood flow back to the right side of the heart so it can go back through, get oxygenated, and go through the body again. All right, so we said TEDS, we said elevating that extremity. Have to be careful with certain surgeries, especially with hips. You have a lot of different rules you have to follow with hips, but if that was something you could do, absolutely. What else can we do? What if your patient doesn't like TEDS? They're too tight, they don't want them. What else can you do?
Yes,
Do you do warm compress?
wraps.
Wraps? Yep, like a
Or warm
like an
compress?
ACE wrap. You can do an ACE wrap. What else can you put? What are those machines that we put at the end of the bed that we wrap our patients' legs in?
SCD.
Yep, SCDs. What else can we do to promote circulation?
Getting them up and walking.
Yes, who said that?
Shanoa.
Shanoa, very good. Get that patient out of bed. Patients that come to the unit after they have knee replacements, they're up within 2 hours. If they have an early hip surgery or an early knee surgery, they're up by the afternoon. They get them out of bed right away. Get them out of bed, get them to this goes for any patient. Get them out of the bed, get them into the chair, move the patient. And then you can also administer those low dose heparins and then other different anticoagulants like Lovenox and things like that that are going to help prevent clot formation. So another thing that can happen is compartment syndrome. This usually occurs on our extremities, our arms and our legs. So this happens when tissue perfusion in the muscle compartment. So our muscles are covered by like a fascia that is not very elastic. It doesn't move a lot. And that area becomes compromised secondary to tissue swelling, hemorrhage if blood fills up in that area, or if we have applied a cast that could be too tight. So this is a very dangerous situation. If circulation is not restored, then ischemia and tissue anoxia can occur. This is going to lead to permanent nerve damage. It can cause muscle atrophy and contracture, or ultimately they could end up getting their, if the ischemia is bad enough, they could end up losing that limb. So when we think about compartment syndrome, you want to think about the 5 Ps. So what type of pain do they have? So usually these patients are going to complain of unrelenting severe pain that is not managed by analgesics. No matter how much pain medicine you give them, they are going to be in excruciating pain. Paralysis. So do they have any feeling in their arm? Can they, wherever this compartment syndrome is, do they have feeling in that area? Then we think about pallor. So pallor is the color of the tissue. So we want to look and see, is this extremity pale? Are the nail beds cyanotic? And then we think about pulselessness. So we're feeling for those. So if it's in the arm, we're checking those radial pulses, those brachial pulses. If it's in the leg, we're doing the popliteals and the femoral, depending on where it is. If we don't feel pulses, that's a problem. It only takes about 4 to 6 hours for neuromuscular damage to occur. That's not a long time. The way we treat compartment syndrome is we do what's called a fasciotomy. It is a surgical incision, so they have to go back into the OR. They make an incision through that subcutaneous tissue and that fascia of that affected compartment to help relieve that pressure and then to restore that circulation. So how can we prevent this from happening? We want to monitor our client for signs and symptoms. Those 5 things, right? That unrelenting pain. We want to apply, elevate the extremity. We want to apply ice. Make sure we are performing our neurovascular checks to help prevent this complication. And as indicated, relieve pressure by loosening a cast or preparing the patient for that fasciotomy, which is a surgical incision that we just talked about. Delayed wound healing. Delayed bone healing. So this is when the bone fails to heal at the expected rate. So this can occur as a result of non-union, which is Non-union is when the ends of those fractured bones fail to unite and heal for whatever reason. Or it may result in malunion. So malunion is when the ends of those fractured bones heal, but it's in a deformed position. And then we have avascular necrosis. This is a condition that occurs from interruption of blood supply to the fractured fragments after that bone tissue dies. And we most commonly see this in the femoral head. So your patients are also subject to developing a fat embolism. So a fat embolism is fat globules that come from that bone marrow. They're released into the blood circulation. They combine with the platelets and they form emboli. Those emboli travel through our vasculature and they travel to the small blood vessels in the lungs. They result in acute respiratory insufficiency, and then you're going to have impaired organ perfusion. So the signs and symptoms, this usually occurs within 48 to 72 hours. Your patients are going to be dyspneic. They're going to be short of breath. They're going to have an increased respiratory rate because they're having trouble breathing. Their oxygen saturation is going to be decreased. They might complain of a headache. They might have confusion related to that decreased oxygen level. They're going to be tachycardic. Why are they going to be tachycardic?
Because they can barely breathe.
Yes, but what's happening in the body?
Body's not getting the oxygen it needs. It's the heart's just trying to beat faster to get where it needs to go with that oxygen.
Yes, so the tachycardia is a compensatory mechanism. So if we aren't getting enough oxygen in our body, our heart thinks that we're not getting enough blood out. So it's like, oh, okay, well, I'm not giving it enough blood. I have to pump more blood out. So the heart starts beating faster, compensatory mechanism. They might have chest pain. So what is the treatment? We're going to give oxygen for respiratory compromise. We're going to give them, we might give them corticosteroids for cerebral edema. They might get vasopressors. Vasopressors are a very powerful group of drugs that induce vasoconstriction, and they elevate the mean arterial pressure. We're going to do fluid replacement for shock, and then pain and anti-anxiety medications. Why might we give anti-anxiety medications?
To help keep them calm, help get their respiratory rate under control.
Yes. So when people can't breathe, they panic. It's a very scary feeling not to be able to breathe. So those anti-anxiety, a lot of patients that have COPD take a lot of anxiety medicines because they always feel like they can't breathe, and it's pretty scary. They might develop osteomyelitis. So osteomyelitis is an infection of the bone that begins initially as anti-inflammatory situation with the bone, and then it is secondary to an infectious organism. So either a bacteria, a virus, or a fungi, usually followed by trauma or a surgical repair of a fracture. So signs, it's an infection of the bone, basically. So signs and symptoms are going to be bone pain. They're going to report constant pain. They might say that it's pulsating. It's going to be very well localized, and it's going to be worse with movement. They might have erythema and swelling. What's erythema?
Redness.
Redness, yep, and edema. How do we treat? This is a long course of treatment. So these patients usually get a 3-month of IV antibiotics and or oral antibiotic therapy. So if we don't keep them in the hospital for 3 months if they need IV therapy, they usually get a PICC line and then they go into a center. However often they get their antibiotics weekly, or they have a home care nurse that comes and does it, or they can stay on oral antibiotic therapy. Sometimes they have to go in and do surgical debridement. Sometimes we send them to hyperbaric oxygen treatment, so it gets all that oxygen-rich blood to that area to help heal and get rid of the infection. Sometimes they do surgically implanted antibiotic beads that they put them in there and they just start releasing antibiotics to help get rid of the infection. Unsuccessful treatment can also result in amputation, and it can also result in death. So I took care of a patient who had, I forget what she had. It was, it happens when you're a child, and it's when your spinal, when you're born, you have like your spinal area comes out on the outside of spina bifida. She was born with spina bifida, and her parents couldn't take care of her. She's always been in some type of a home. Well, she had been, I think she was like 27 years old when she started coming to us. So she started refusing her turns. She didn't want to turn in the bed. So she developed a wound. And then when she started coming to us in the hospital, her wound was only like this big. It was like the size of a $50. Right before she died, which was like 4 years later, it encompassed her entire back, literally from one side to the other. I mean, it was humongous. It took two of us to like hold her and pack it and cover it. Well, because the infection was so bad, it went to her bone. And we knew that she was going to die because you can't really, it's very hard to treat osteomyelitis. If you catch it early, sometimes you're very successful, but left in these chronic states, it's very hard to treat. And that she died 4 years after, I mean, I don't know how long, I guess it was like 4 or 5 years total, maybe 6. But she did eventually die. She was in our hospital all the time, and we all took turns taking care of her. We all knew her. We knew her family. But she died when she was 28 years old, and that's what she died from, the osteomyelitis. So it is very serious. Fractured hips. We're going to see a lot of these. So usually a hip fracture affects the proximal end of the femur. That is the most common type that we see. This type of fracture usually results from a fall, and obviously it is very frequent in our older patients with osteoporosis. Usually the falls themselves are not very traumatic, but it's the client's condition that contributes to the resulting fracture. So assessment findings, what are we going to see? Our patients are going to be in severe pain. It is going to increase with any type of leg movement. It radiates from the hip all the way to the knee. I've heard patients say in their toes they can feel it. They feel like they have an increased pressure in that outer aspect of the hip. You might see a discontinuity of that bone and that muscle spasm together, which will cause a shortening of the leg, and then it will cause an external rotation of the leg. You might have blood loss, which could cause hypovolemic shock. You will have extensive bruising, swelling that can not only be in the hip area, but it can also go into the groin and the thigh as well. Sometimes you have contained bleeding. So you have bleeding, but it's inside that joint capsule. We usually see this with intracapsular fractures. We're going to talk about those. So how do we diagnose a hip fracture? X-rays, CT scans, MRIs. How do we manage them? So usually the only option is to do surgery or not to do surgery. So you can do a total hip arthroplasty. So this consists of replacing both the acetabulum and the femoral head. You can do a hemiarthroplasty. So this is where the fractured head and neck is removed and it's replaced with a metal device. The bone heals around that metallic device that's implanted. And then it holds that bone together. The bone is united immediately, and clients are mobilized much earlier than they are if they have to go into traction. So nurse management, we are going to implement measures to prevent skin breakdown. So we're going to monitor those incisions for redness and swelling and purulent drainage, which would signal wound infection. We are going to prevent pneumonia. How do we prevent pneumonia in these patients? Why do
Begin to cough,
yes,
breathing and coughing.
incentive spirometer, turn, cough, and deep breathe. Yes. So those patients, remember, we put everything to sleep. The lungs are no different. They're affected by them. You get post-operatively, is that 24 hours after you have that surgery, you're at your greatest risk for developing atelectasis, where all those little bronchi, they kind of like close up, which means that you can't get good air in there. All these things lead together. They're not moving in bed. They're not taking in good breaths. Some of them don't take deep breaths because they're in pain. This all leads to the risk of pneumonia. So getting your patients out of bed into that chair, encouraging them if they're in bed to get in that high Fowler's position if they can. Incentive spirometers. We're going to manage constipation. We know why they're going to get constipated. We're giving them pain medicine. They've had general anesthesia. They're not moving. Sometimes urinary retention we see as well. This is not uncommon because even the kidneys go to sleep. It takes a while sometimes for that process to start back up again. Sometimes we see muscle atrophy and contractions. Usually you see those when there's been like a little bit of a time. So sometimes patients have hip fractures and they still walk around and they don't even really realize it. And they just have like this nagging pain. And then eventually they go to the doctors and they're like, oh yeah, you have a broken hip. So when we turn our patients from side to side, we need to make sure that they have an abductor pillow between their legs, because that we want to teach our patient to avoid adduction of the affected leg and not to flex those hips between beyond 90 degrees, because it can cause that hip to pop out of socket. And then most importantly, we are going to want to explore ways to ensure safety in that patient's home, because we want to avoid future injuries and falls. So that's important. You guys need to know that. You want to ask questions about what's going on in their home, because they've already had a fracture. We don't want anything else to happen to them when they get home. All right, so now we're going to talk about casts. So a cast is a rigid mold that immobilizes an injured structure, giving it an opportunity to heal. Casts are applied usually to keep aligned bone fragments from being displaced. The cast is always applied from the joint above the break to the joint below the break. Usually casts are fiberglass or plaster of Paris. They offer alignment and support to that fractured area. Depending on the degree of swelling when they go to put that cast on, initially they might apply a plaster of Paris cast until that swelling subsides, because what are you trying to avoid? What could happen if there's swelling in there and you put that cast on? What could we cause? We just talked about it.
Compartment syndrome.
Very good, compartment syndrome. So prior to the casting, they make sure that the area is very clean and very dry. They put what is called a stockinette over top of that area, and it goes under the skin. It helps to maintain skin integrity under that cast. They usually wrap padding over top of that, especially over any areas that are bony. They apply rolls of strips of plaster or non-plaster, depending on what they're using, over that stockinette and the padding. The cast material, as they're getting it on, feels very warm. Once the cast is complete, they send the patient back to X-ray to check for bone alignment, because you don't want to put that cast on and then not have the bones be aligned. So they send the patient for an X-ray. During the first 24 to 48 hours after getting the cast, you want to educate your patients to keep that cast above the level of the heart, because we want to prevent edema from that affected extremity. We don't want that swelling that can lead to that compartment syndrome. We want to make sure that the cast is not too tight. There should be enough room for one finger to get in between the skin and the cast. After the cast dries, they can go back in sometimes and they cut what's called a cast window or an opening. They usually do this when the client reports discomfort under the skin, or that sometimes there's a wound under there that requires a dressing change. So the window permits the healthcare provider to inspect the skin. It can also be a means to check a pulse in a casted arm or a leg. Once the window is cut, the solid piece of that cast that originally was cut is replaced in its original site, and it's secured with adhesive tape or a roller bandage. Leaving the window open may allow the skin and that soft tissue to expand and bulge through that opening. So that's why you have to replace that window with that little piece that you cut out. So what type of cast? There is a bivalve cast, which is the one here, which is actually cut in two. Once the cast is applied, then they take it and they bivalve it or they cut it in two. They use this with a swollen arm or a limb that causes the cast to compress the tissue, and it could compromise the blood flow. When a patient is being weaned from a complete cast, when radiographs are needed, when certain radiographs are needed, such as sharp radiographs, and they also use it as a splint sometimes for immobilizing painful joints for people who have arthritis. So nursing management for casts, we're going to instruct the patient not to place any foreign objects inside the cast to avoid trauma to the skin. So patients, this area is very dark and it's very warm and it starts to itch. So you'll see people sometimes take the end of hangers, they'll stick pencils in there, anything they can to try and itch it because it's very, very itchy. You want to instruct them to cover the cast during baths and showers because you don't want to get it wet. And you want them to report any changes in mobility or complications such as shortness of breath. So what are we thinking if a patient reports shortness of breath? What are we thinking is going on?
A fat emboli?
Could be a fat emboli, or what else? A pulmonary embolism, right? You always want to think that. If your patient has shortness of breath, you always want to think pulmonary embolism. And then you want them to report if all of a sudden it's swollen or it's red, and then constipation. So cast removal. So casts are removed with a cast saw. If you are assisting to do this or you are doing it, you want to make sure you wear gloves and protective eyewear for you and the patient, and of course a mask, because all those little fibers are coming up. It can get in your eye, it can get in your respiratory tract. You want to make sure that you explain this procedure and show the client the saw before you start removing it, because this is a scary thing. People are afraid that you're going to cut through and saw their arm. I mean, it's a real concern. This is especially true with children and parents. You want to make sure that you explain to them, explain that the skin under that cast might be covered with scales or crusts of dead skin. The muscles in that arm can also appear atrophied, and then that limb may also feel weak or stiff. These are all normal things that will subside after that cast is removed and you start using that arm like you used to be able to use it, or wherever, whatever body part. After the cast is removed, the client may wear another type of a brace for a week or two just to give that some extra stability to that injured area. And then every healthcare team member is responsible for instructing that client about therapeutic exercises for that original injury. All right, splints and braces. So splints act to immobilize and support an injured body area in a functional position. We would use a splint with a musculoskeletal condition that does not require rigid immobilization. So if it's a severe injury, you would not just want to use a splint. You would use a splint for a musculoskeletal condition that causes a large degree of swelling because it can be removed. And if if it requires special skin treatment because it's easily accessed. Braces provide support, they help control movement, and they prevent additional injury and are usually used for a more long-term use compared to splints, which are usually short-term use. You want to make sure you provide the client and the family education about how to put these braces on, so you make sure they're using them in the right way. And then you want to educate them about any skin care that may be needed to prevent irritation or any injuries. So traction. I have never in my life seen traction in the nursing, in my experience as a nurse. I know that a lot of orthopedic floors use them. I've been on a couple different orthopedic floors and I've never seen this. But it does exist, so that's why we teach you about it. So treating a fracture sometimes involves you have to get your limb or that injury into a proper alignment to that injured bone. Treatment of fractures include one or more methods. Sometimes you use these in combination. So you could just have traction. You could have closed or open reduction. We're going to talk about that. You could have internal or external fixation or just a cast. So traction is used to relieve muscle spasms. It helps align those bones and it helps maintain immobilization so that that bone can heal and the patient cannot move it. When we talk about closed reduction, this is when the bone is restored to its normal position by external manipulation. And by external manipulation, we mean a bandage of some type, a cast, or traction. So we do it all from the outside of the body. There's no type of surgical intervention in closed reduction. It's closed. When we think about open reduction, so open reduction means we're going in and we're opening up that area. It's performed in the operating room and the bones are surgically exposed and then realigned. With internal fixation, this is when external fixation is needed to stabilize the reduced fracture. So the surgeon secures the bone with metal screws, sometimes plates and rods, nails, or even pins. So this is internal, right? It goes in the body. A cast or other method of immobilization is then applied afterwards. Then we have external fixation, which is where the surgeon inserts metal pins into the bone from the outside or into the bone directly or into the bone from the outside of the skin. So when we think about nursing care, and this is important, I want you guys to remember this, when we talk about nursing management for a person that has some type of external fixation, they're gonna have what we call pins, okay, that are hanging out of this injury. So you are going to need to make sure that you provide pin care for your patient. There's usually a solution that comes from pharmacy. Usually the doctor decides. There's a couple different ones. The doctor usually has a particular kind that he likes to use and he'll prescribe it. And you're doing it frequently. Usually it's several times throughout the day, but it varies depending on how the doctor wants it. The pin sites are an entry site for an infection. They're sitting out in the open air, but then they're also going into the body. So you're going to make sure you're cleaning those pins every day or however the doctor orders it. You're going to make sure that you are monitoring this area for redness, swelling, and any kind of drainage or tenderness. Usually when you do pin care, you use a cotton swab for each pin because you don't want to have cross-contamination. So you usually gather a whole bunch of them. They're usually sterile in a container. You take one out, you use your solution, you clean off one area, you get rid of it. Then you grab another. You use as many as you need to clean off each area where it's going into the skin. And then you would also want to protect any bony prominences from pressure. So by using different pressure relieving techniques or maybe you cover it with padding, you just want to be very conscious of those bony areas so that they don't get more skin breakdown. So this is an example of an external fixator. So you would want to, why does that look like that? Hold on. Okay. So this is your external fixator. You can see all these little pins here going into the skin. There's one here. So you would want to make sure you are cleaning those every day. And then any bony areas, like maybe at the back of the foot right here where that ankle bone is, that could be a sore site. So you would want to make sure that you would maybe put some kind of cloth under it or keep it elevated so that the ankle's not sitting on that area. All right, so we use these external fixators to manage very complex fractures. Sometimes they are also associated with soft tissue damage or open wounds in that fracture area. Wounds that are associated with injury have to be very closely monitored for signs of infection. And then clients more mobile than if confined to a bed traction. So this is an advantage to using the external fixator. So it minimizes the need for traction. But then you have to lug this around. So it just depends. Usually it's a surgeon's preference what he decides to use. So then we have open reduction internal fixation. We call this ORIF. So usually if you're working on a surgical floor, that's how they say the patient is status post an ORIF. Those are your nursing words. So this is visualization of a fracture through an incision in the skin. They add internal fixation with either plates, screws, rods, different prosthetics. You might have nails. There's stuff called an intermedullary rod, different internal fixation devices. There's all kinds of stuff out there. And then we have joint dysfunction correction. So you can have an arthroplasty, which is surgery to reshape, reconstruct, or replace a disease or damaged joint. Or you can have arthrodesis, which is actually the fusion of two bones, and then they don't rub together anymore. You can have osteotomy, which is surgery that involves cutting and removing a wedge of your bone. Sometimes we see this with tibia injuries and femur injuries. We do this to change the bone's alignment and improve function and to help relieve pain. We have the total arthroplasty and the hemiarthroplasty. We already talked about those for those hip replacements. So we want to carefully monitor our people who have these immobilization devices because it's extremely important, right, that we want to prevent and promptly treat any complications. So any areas of concern, such as pressure. We don't want to have any skin breakdown. We don't want to cause any more problems than we already have. We want to watch for infections of the wound or the bone. And then we want to watch for any hemorrhage. So again, we have that patient who had that ORIF, right, of his right femur, and you go in to assess your patient and his foot is very cold, cool, or it's very pale. What would you do if you stumbled across that situation?
Check for a pulse.
Yep, you would check for a pulse. So what if you don't have one? Or it's very, 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 very weak? Then what would you do?
Notify the physician.
Yes, call the doctor. Very good. That is an emergency situation. So you would want to call the doctor. Very good. All right, so this is just different things that different tractions and stabilizers that they use in the orthopedic, in different orthopedic surgeries. I don't expect you to know that. I was just giving you a little bit of insight into the different ones that they use. So before surgery, before patients go in, the nurse, they have a surgical nurse who obtains a complete medical history on the patient. They do a complete drug history and an allergy form from either the patient or a family member. Maybe the patient's a poor historian or they're confused, so then you would want to talk to that family member. The nurse is also going to assess the client's physical condition and their mental status at the time of the initial interview. We are going to review the client's chart. We're going to be looking at their diagnosis. the type of surgery that they're going to be performing, and then any previous treatments that they've had. So have they been treated with certain drugs, corticosteroids, or have they tried traction? If, and this is important, you guys need to know this, and it's not written down here, so you might want to write it down. If you have a patient who has a disorder that was previously treated, so maybe Mr. Jones came in and he's going to have a knee replacement today, but he also had a knee replacement 10 years ago. Sometimes these knee replacements and these hip replacements are only good for 10 years. So if they have them at a certain time in their life, it is possible that you could see them again and they might be having another one. You're going to want to determine if there were any complications or problems that occurred because of or during that treatment, okay? Because this gives you an idea of what to expect. So if they've had this injury and it's been previously treated, you need to determine whether there were any previous complications or problems that occurred the first time. You want to talk to your patients and help control their anxiety. You want to educate them, make sure that they understand their instructions. There's a lot of things that are going through their mind. You know, maybe they're missing time from work and they're thinking about how they can pay their bills. Maybe they live in a house with a lot of steps and they're wondering who they can get to help them. Maybe they don't have any family member. Maybe they don't have insurance and they're figuring out how they're going to pay for this. Maybe they're just scared to go under general anesthesia. So when patients are dealing with all these different situations, they're not really paying attention to your instructions. So it's always a good idea to have someone else with them and then educate both of them. So that way, if the patient forgets something, then they have somebody else with them that can refresh their memory. You want to make sure that they are going to be NPO at midnight, the night before the surgery. We don't want them to have anything to eat or drink because the anesthesia can cause them to vomit. It can make them sick and they can aspirate and it can go into their lungs and they can get aspiration pneumonia. The night before, poor Alan, he keeps getting thrown out. The night before and the morning of, you're going to want to take a shower with CHG soap and wipes. Usually the surgeon provides you with this. And then you're going to teach your client to withhold administration of aspirin or certain herbal supplements before surgery. Why do you think that we would want to hold aspirin before a surgery?
Because it thins your blood out.
Because of bleeding?
Causes an increased risk of bleeding, yes. So sometimes you'll see if the patient's coming from a unit in the hospital, there's been multiple times where my patient's going for surgery that day and they have a 9 o'clock dose of heparin. So that is up to you to recognize that this is not something you would want to give and then use your critical thinking skills and hold that heparin. Because a lot of patients come into the hospital because they've had a fall and then they have this broken hip or this broken knee and then they go to surgery from your unit and then they come back to you. So that's when you would see that heparin. Whoops. All right, so post-operative nursing management. This actually begins before surgery. We have demonstrations of, we're teaching them how to deep breathe and those coughing exercises. And we demonstrate how to use incentive spirometers. This does not always happen in the hospital, but this happens if you, this is a case where this is happening outpatient. You're going to your doctor and he's like, look, you need to have a knee replacement. Look, you need to have a hip replacement. They're going to bring you in. You're going to meet with one of the nurses there and they're going to go over all this stuff with you because they want you to know how to do all this when they send you home. So they do it all in their office before you actually have the surgery. We don't want them to get pneumonia. We want them to be able to know how to cough, turn, and deep breathe and how to use that incentive spirometer. We want to educate them about any post-operative devices they're going to have, if they're going to go home with any IV infusions, if they had to have blood, if they're going to need oxygen, if they've had a surgery, they might have a wound drain that they're going to go home with. We might send them home with TED stockings or SEDs. Some patients go home with SEDs and they keep them at home and they do them, I think it's for 7 days after surgery, or any bandages. We're going to want to educate them about that. We are going to reduce the risk for excessive bleeding. So as the nurse, we're going to educate them in the outpatient setting to stop that aspirin Or sometimes we tell them if they take Plavix, that also thins their blood. We want them to stop that before a certain time. Any other kind of blood thinners that they take. And then if they're inpatient, making sure they're not having heparin. So heparin has a very short half-life. So usually you stop at about 8 hours before surgery. You want to monitor their labs. We want to monitor, what could we monitor that's going to show us if they have a bleed? Dina, are you talking? Because you're muted. I can see your lips moving. I didn't.
I was like, nobody, but no. It's not platelets. It's called
Hemoglobin.
yes, hemoglobin and hematocrit. Thank you,
Very-
whoever said hemoglobin.
Very good. So, and it can also be your platelets because your platelets are in your blood. So if you have low levels of blood, in turn, you're going to have low levels of platelets. So good. You want to do that complete blood count and monitor that blood count. You want to look at your prothrombin time and your bleeding and clotting factors to make sure that they have the ability to control their bleeding and make sure that they're not overcompensating and that they're at risk for a blood clot. You want to make sure you are reviewing their physician order. So some patients we don't have this in our hospital, but some patients have a continuous passive movement machine, which they give them after surgery, and some clients have to be fitted for this, and it helps them keeping their joints moved and stuff like that. And it just helps them keep that range of motion. But the physician would have to set up the degree of flexion that they want. So look at those orders, make sure that if they've had a hip surgery, that they have all the precautions in there that they want, like that adduction pillow and different implementations. Help reduce pain and inflammation. So give those prescribed medications that the doctor has ordered. You're going to want to make sure you are inspecting that dressing over the incision. So where I work and the patients that I take care of, usually they have what's called an Aquacel dressing. It's a very thick dressing. If it's a hip dressing, it's usually this long and it runs along that whole long incision in the hip. We also do them for the knees. These are considered surgical incisions that we don't take off. They will take off those dressings when they go back to their primary care doctor when they're discharged to follow up. You want to monitor that dressing to make sure that it's clean, dry, and intact. And you want to look at it as soon as they come out of surgery, because if they come out of surgery and there's a little dot of blood, you put a little circle around it. And then if you come back 4 hours later and then there's even more blood, well, then that's going to signal to you that something's not right. The patient has some kind of bleeding. So you're kind of constantly looking at that dressing. If the wound has a drain, you're going to assess the patency of that drain. You want to look at the amount of fluid that it's putting out. And what type of fluid? What does that fluid look like? Sometimes it's pus, sometimes it's brown, sometimes it's serosanguinous, just depends on where it's coming from. And you're going to want to, every 4 hours, you're going to want to measure that, the output and put it in your eyes and nose. You're going to assess those neurovascular assessments, right? You're going to be checking for pulses of that affected extremity. You're going to monitor vital signs until they stabilize, because if they are bleeding somewhere, you're going to see it in their vital signs. If they have an infection, you're going to see it in their vital signs. You're going to maintain IV fluid if it's ordered. You're going to want to assess their respiratory status, right? Why are we going to assess their respiratory status?
Pulmonary embolism.
Mm-hmm. Very good. I love that you guys are answering. It's always the same people answering. I need other people. Not that I don't want to hear from you. No. Don't take that the wrong way, Dina. I'm not. But I think a lot of people don't answer because they're afraid of saying the wrong things. I don't want you to be afraid. I need more people to participate. I want everybody to take a guess at these things. This is how you learn. So many times in nursing school, I guessed and it was the wrong thing, and it was completely okay. That's how you learn. This is a comfortable environment. I hope you didn't take that the wrong way, Dina. I'm sorry. I did not mean it that way. And if you know the answer, please keep saying it. I'm just saying I want other people to also try. What else? Fluids. Assess that respiratory status. Encourage the client to identify if they have pain. Some people don't want to express if they have pain. I see this a lot in the male population because they feel like, you know, it's not manly if you have pain, or I don't want to be a complainer. Well, you know, if you have a hip replacement or a hip fracture or some kind of surgery, there's real pain associated with that. And you want to explain that to them. Maybe they're afraid of getting addicted to pain medication. That's also a real fear for some people. So you want to educate them and explain to them that if they're using the least dose to be effective for the smallest amount of time, that they should not have that issue. And we want to prevent post-operative complications. What are post-operative complications? What can we see?
Pneumonia.
Pneumonia, what else?
Skin breakdown.
What else? Pneumonia, skin breakdown.
Infection.
Infection, yep. Pneumonia, skin breakdown, infection. What else?
Blood clots.
Very good, blood clots. Those are, you guys are doing a good job. Those are all the things you need to think about. You guys are thinking like nurses. All right. So teaching, we want to be a support system. We want to make sure that they have a support system after discharge. If they've had a total hip replacement and they're using crutches or walkers or canes, you want to make sure that if they have steps in their home, you have someone there to help them. You just want to make sure they're supported. Explore the kinds of assistance that they're going to need. Get in touch with that social worker and say, look, Mrs. Jones is 85 years old. She has 12 flights of steps to get into her house. She cannot go home. She needs to go to subacute rehab. Advocate for your patients. Modifications that are needed in their home environment. Sometimes that's a possibility. So maybe they can't get maybe their toilet is really low. We could give them a raised toilet seat. Maybe we could give them maybe they won't be able to, maybe they can get in the shower, but they won't be able to stand up in the shower for hours on end. So we could give them a little shower chair. Give them information about home care. Maybe they aren't good at taking care of their wounds and they have a drainage, like a JP drain or something like that, and they can't do it. Make sure that they have home care set up. Referral to home healthcare agencies. Make sure you print their discharge instructions because remember we said this is overwhelming, and when they get home, they're going to forget, oh my God, how often am I supposed to empty this? What am I supposed to do if this happens? All the most frequently asked questions are always in the discharge instructions. And then you want to make sure that they are adhering to activity orders, physical therapy, and that they know when to report certain symptoms. All right, so this is just pictures of hip replacements. So this is before, and this is what it looks like after. These pictures are in your book. If you want to go to your book, you can look at them. All right, so positioning precautions with hip replacements. So until the hip prosthesis completely stabilizes after that hip replacement surgery, the client is going to need to know and be educated about proper positioning because we want that prosthesis to remain in place. And if they do certain things, it can cause it to pop out and then they have to go back into surgery. No one wants that. So dislocation of the hip is a very serious complication of surgery. It can cause pain and it necessitates reoperation to correct that dislocation. Desirable positions include abduction, neutral rotation, and flexion of less than 90 degrees. So when the client is seated, the knees should be lower than the hip. You guys need to know this. The knees should be lower than the hip, and then we want to make sure that they are keeping their knees apart at all times. They want to have their legs abducted with pillows or an abductor cushion and extended. because the opposite positions of adduction and flexion that occur beyond that 90 degrees, that's what causes the dislocation of that prosthetic head. You want to prescribe medications as needed, those analgesics. Sometimes they take antibiotics prophylactically to avoid an infection, and then those anticoagulants. A lot of these patients go home with, they'll take Lovenox injections once a day for 30 days. Sometimes they go home with SEDs. Just depends on who the physician is. Each physician has their own things that they like to use. You want to make sure that when you're sleeping, you put a pillow between the legs when sleeping. When you are sitting down, never cross your legs. You want to avoid bending forward when you're sitting in a chair. Avoid bending forward to pick up an object on the floor. So you'll see that I know where we work, we give the patients little grabbers, because if something falls on the floor, they need to be able to bend, you don't want them to bend over and get them. So we give them these grabbers that helps them pick stuff up. They can use a raised toilet seat. You don't want them to flex that hip to put on clothes, such as pants, their stockings, their socks, or their shoes. And then provide a grabber. We've talked about that. If the hospital doesn't give one, they can buy one. And this is a picture of a knee replacement. So you can see how that knee looks before. There's like no cartilage in there. It's bone on bone. So that is what is extremely extremely painful. And this is what it looks like when they put the replacement knee in there. And like I said, these are usually good for, I'd say 10 to 12 years. I see patients sometimes 12 years that come in and have to have replacements again. Can you guys hear my husband and my son downstairs? Yeah. Hold on. Larry. Hello. I'm teaching. You're talking. I'm always teaching on Tuesday night. This isn't new. Okay. All right, so knee replacements. When we educate our patients about knee replacements, we want to, let's see, we want them to start moving that leg as soon as they get out. So ideally, if they get out of surgery before noon, at least at my hospital, they're having physical therapy and they have them up and walking by 3 or 4 o'clock. Usually if they come out later, it doesn't happen till the next day. The goal for your knee replacement patients is to have the ability to bend the knee 90 degrees by discharge. Sometimes different physicians will prescribe that continuous passive motion machine, which helps promote motion in the knee. It also helps to promote circulation, and it prevents the formation of scar tissue inside there, which can eventually, over time, limit their mobility. You want to apply ice or cold therapy constantly to the incisional area because you're reducing pain and that post-operative swelling. You want to provide medication, so those analgesics, sometimes those prophylactic antibiotics, and those anticoagulants. We are also going to monitor neurovascular status. We're going to be looking for movement. Can it move? We're going to look for sensation. Do they have feeling there? Do they have numbness or tingling? You want to look at the color. So is it, is the color appropriate for ethnicity, or is it bright red, like there's some kind of erythema there, or is it pale, like it's not getting any blood? You want to feel for that pulse, and then check that capillary refill, which are signs of blood flow to that extremity. You're going to be doing it every 2 to 4 hours. We do it at our hospital 4 hours, and then you want to compare that with their other extremity, right? Because we're always comparing with the other extremity. You want to monitor that incision for fever, any increased redness, purulent drainage, any swelling. We're monitoring for those DVTs, right? So we're looking for swelling in those calves, any redness in the calves, any pain, pulmonary embolism. Your patient is going to say that they have shortness of breath. They might even complain of chest pain. and then any bleeding. Sometimes they might have internal bleeding, so that's why we look at those labs, because that would signal if something's going on inside that we cannot see. And then we want to make sure that they are adhering with their physical therapy again, so they can help regain that mobility. So nursing diagnoses for these patients. Total hip and total knee, we might see disturbed body image related to large scar in the presence of a prosthesis, impaired physical mobility related to musculoskeletal impairment, surgery, or prosthesis, risk for injury, neurovascular injury, which could be caused by altered peripheral tissue perfusion, right? We're not getting that good blood flow to that to the tissue. Impaired mobility or prosthesis, risk for peripheral neurovascular dysfunction caused by related to immobilization and a surgical procedure. And then we have ineffective peripheral tissue perfusion related to surgery. So if we talk about what would be a good expected outcome. So if we think about that patient, you might be taking care of a patient that has that external fixation, right, on the outside of, just say it's their leg. A nursing diagnosis for that patient could be impaired skin integrity, right? Because we have something, we had to open the skin, we had to make an incision in the skin to put these pins in. So impaired skin integrity related to wounds and pins. What would be a good outcome for that patient?
To
What do you
remain free of infection.
Yes, very good. Good job, Heather. So that that wound heals without infection. You might see that again somewhere, by the way. Just saying. All right, and that's it for mobility 2. So we do have your questions, your quiz questions to go over.